Good morning. Welcome on a Friday morning. I'm really impressed. Good for you. My name is Meghan Phillipp. I serve as the Executive Director of HC3, the Healthcare Council of Chicago, and I'm so proud to welcome you to our Q3 Summit focused on the future of data in healthcare. We are owned and operated by a parent organization called Third Horizon, which is a national advisory firm focused on the future of health. But HC3 is a platform that really does exactly this. We try to create community intersectionality across our healthcare ecosystem, bringing the biggest and boldest topics to you, and then also partnering with our communities to make those actual realities a solution. So I'm really excited about today's lineup to hear from some really thoughtful experts and friends and colleagues talking about a very, I think, controversial, but also shouldn't be controversial topic. And we'll dig into all of those things across public health and innovation and lots of great things. To kick it off, we have our public health panel that's going to be led by my colleague, Ashley DeGarmo, the Chief Client Services Officer at Third Horizon. So thank you, Ashley.
Hi, good morning. Happy Friday. Let me know if you can hear me or I need to speak louder. So as Meghan mentioned, I am the Chief Client Officer. I don't have data in my title. I don't manipulate data. And so when Meghan asked me to facilitate this, I said, why me? But I do have a strong appreciation for data, particularly in this topic and the role that data plays in actually emphasizing the importance of strategies and making change on the ground. And so I'm so grateful to lead this panel with actual data experts here. And so I will introduce everyone, share where they're from, but I'll let them give much more of a introduction about their work as we kind of go through the discussion. So I'll start Roy Ahn. He's the Vice President of Public Health from NORC at the University of Chicago. We have Heather Blonsky. She is the Vice President of Data at Metopio. We have just read this. No, you're good. Shelly Sital. She wears many hats, as I learned during the prep call. And so I'll ask her to speak to a lot of these hats. But for purposes of my introduction, she's the Director of Public Health Initiatives at AllianceChicago. And lastly, next to me, Dr. Alfreda Holloway, the Director of Epidemiology at the Cook County Department of Public Health. So where we're going to go in this discussion, I'd love to really focus on three things. First, have a talk about collaboration, transparency, working together to build trust in data ecosystems. Then we want to move into taking data and making actionable change, how that impacts policy, insights, and then the last thing we'll talk about, because we couldn't have a conversation without AI when we're talking about data, is innovations, what we're excited about, what guardrails we should be thinking about in the future as it comes to data and public health. Sound good? Awesome. So, Shelly, I would love to start with you, with both your hats on, to talk about how the collaboration and trust comes into play with the work you do. And if you could share a bit about Capricorn and AllianceChicago so the group knows what we're referring to, that'd be great.
Thanks. Can everyone hear me? Okay, wonderful. So I'll start with Capricorn. So if folks aren't familiar, Capricorn is, in light of not having a health information exchange in the state of Illinois, it's a collaboration of 10, now almost 12, we're waiting on 2 agreements to be finalized, large health systems in the Chicagoland region. So think Rush, Northwestern, Loyola, University of Chicago, UIC Health, Endeavor, which used to be North Shore. I always get their name wrong now. We have soon to be joining us Advocate, Sinai Health, and some other folks too. Essentially, 11 years ago now, these health systems came together, and in addition to AllianceChicago, which I'll speak to in just a second, and that's where I work, where I get paid to work, Capricorn came together with the understanding that there was no health information exchange in the state, which meant that there wasn't really a great way to share de-identified data and do population health work across the state using electronic health record data. So originally it was funded by PCORI, which, if you're not familiar, is the Patient-Centered Outcomes Research Institute, which was funded through the Affordable Care Act 15 years ago now, I think, almost. And so Capricorn came together with the intention of being able to collaborate and share data. that had obstacles. And I'll talk to that in just a second, but let me speak to Alliance Chicago as well. So I work at Alliance Chicago, which is also a member of Capricorn. Wearing my Alliance Chicago hat, I serve as the Director of Public Health Initiatives. So Alliance Chicago is actually a consortium of federally qualified health centers. And generally across the country, these networks of health centers are referred to as health center controlled networks, HCCNs. And there are 1,400 approximately health centers around the world, around the country. And HCCNs essentially across the country help support not all of those, but subsets of them. So Alliance Chicago, in varying ways, helps support about 80 different health centers. And we have a couple that we're part of their kind of data infrastructure. And the point of HCCNs, just so folks understand, is that an individual health center doesn't have the buying power and the capacity that a health system has, right? A health system like University of Chicago has so much behind it that they can do a lot versus a small health center. Think if you're in Chicago, Erie Family Health, Howard Brown Health, places like that, they have a lot of power, but collectively they have a lot more. And so coming together as a part of a health center controlled network allows health centers to do a lot more. And I don't have to talk about this too much, but with COVID-19, for example, it allowed the health centers to share the experiences they were having and serve their communities better because they were able to share lessons learned on how they were doing with their vaccine campaigns and things like that. So going back to Capricorn, think collaborative work takes a lot of effort because the the health systems that work together for Capricorn are very competitive. If you're in Chicago and you're familiar with the landscape, these health systems literally sit physically next to each other. Rush is across the street from Cook County, who is also part of Capricorn. They're across the street from UI Health. And then around the corner is Jesse Brown VA, right? So there's all of these health systems that sit together, have the same patients that are going to each of them for different needs. And they're competitive. But bringing together this collaboration has enabled so much in the last 11 years. And we can talk about it a little bit more as we go. I don't want to spend the whole time taking up space, but essentially one of the key things up front was establishing trust. We had 6:30 a.m. meetings every other Friday in person at the beginning of this network to really get people together at the same table to understand what is the point of doing all this and how is this distributed data network going to help move the needle forward for healthcare in the city of Chicago and the vicinity, because some of these health systems have hospitals or clinics that are in the greater Cook County area. Some are in Lake, some are in DuPage County. So I'll stop there. I think that kind of answers the question, and I'll let you keep going.
Thank you. That shows so much commitment for those meetings and getting everyone together. So I'm excited to dig in further. Heather, we have a collaboration right on our panel between Metopio and the County Health Department. So first, before we go into that, would you mind sharing what Metopio is, a little bit about your role, and then we can talk about Health Atlas?
So can you hear me? Great. I was going to say I can hear me. So Metopio is a company that provides support for community health needs assessments, community health improvement plans with all of the data that goes into that, what you know about your communities, what you know about how your communities compare to other communities across the country, what you might be aiming at in that health improvement plan, how you're going to measure that outcome, what's going to contribute to that outcome, all that context that goes into knowing what the needs are, knowing what the priorities are, and how you can act. And that's all about the data. It is all about the data. And my role there is Vice President of Data. I am brand new. I've been there for about 6 weeks, but the team has not. The team's been there forever. So we have a team of 4.5 FTEs total that curate that data, that make sure that it is what you need. And when we talk about what the state of data is now, it has never been easy. It has never been just to download and look. And so that's the service we provide, is to make sure that what you're looking at is what you think you're looking at, and that it's providing the information you need and telling the story you need and directing the action you need. So that's it in a nutshell.
And Alfreda, can you share a little bit about how you use Metopio for Health Atlas and how that collaboration came about, as well as a little bit about what Health Atlas is?
Sure. Hi, everyone. I hope you can hear me. I'm a low talker, so I'm going to try to talk louder. So at the Cook County Department of Public Health, we were very interested in like connecting with other epidemiologists throughout the state. We had what we call an Epi Retreat, Elevating Public Health in Illinois. I thought it was clever, but so our Epi Retreat was in 2019, and we brought together all of like the state epidemiologists, and we worked on kind of what were some issues with us. All of us had 3 to 5 year old data. We couldn't get data from the state. We wanted to work on like data use agreements, and we wanted to work together because Cook County and Chicago, we have a lot of epidemiologists, a lot of programmers, a lot of people who can do analyses, but people in rural places don't have that. People have people who are doing epidemiologic work who don't have those titles or training. They just have to learn how to do those reports when they get there. So these were some of the issues throughout the entire state. And we just wanted to use some of our like expertise at the bigger places, but Chicago like has way more epis than us. We probably have at this point about 8 what I call analytical epi people. That's people who bringing the data into the system, analyzing data and things like that. So in 2019, we were just really interested in like, how do we build capacity? How do we do analysis? How do we work together? Can we have like work plans? Can we have something together? So that was 2019. Of course, we know the pandemic happened. And so in 2020, we had all these ideas. We kind of wrote some stuff up, and then we got $200 million from the federal government. And we were like, wait a minute. So people were like, oh, do you have any projects, any plans? Oh, do I have? Like, absolutely. I have some projects that we would love to do. And so that's how we were able to even afford the Health Atlas. So we wanted to do it for a while. And we found out through Chicago Department of Public Health, who had their Health Atlas for many years. They had gone with Metopio and were working with the University of Illinois, Chicago. And so we kind of started to meet and talk around that. And so not only did we get us an atlas, but we got some good co-workers in Chicago Department of Public Health. And so we were able to collaborate with them, the University of Illinois, and Metopio. And we still meet on basically a weekly basis, trying to get together, understanding what the variables, the indicators are in our health atlas, how to calculate the counts and rates, have the same definitions and things like that. And that is a feat in itself. So it's just out the kindness of Chicago's heart that they work with us and collaborate with us, because we don't have any like grant monies for that. But that's because we had the Epi Retreat in 2019, and we just kind of built rapport, and we all try to work together. We try to help other health departments. So it's just a will and testament of like, people in Illinois really want to work together. We really want to provide data to our communities and stakeholders, and only with the funding of COVID could we even begin this. But now we have it, and now it's in our corporate budget. And so that's how we move forward now.
That's great. It's a nice story about COVID funding getting to something sustainable, and you don't always hear kind of the silver lining after that. Roy, so you've led several large-scale projects. How does collaboration and bringing together diverse stakeholders work well in what you do? Can you share a little bit about NORC and your role there?
Sure. So I'm Roy Ahn, and I'm a vice president at NORC at the University of Chicago. We're a nonpartisan nonprofit research organization affiliated with the university, but distinct from it. And we have several hundred researchers in our health practice, and we serve federal, state, foundation clients. Historically, people know us for our opinion research, National Opinion Research Center survey type of work, but we've greatly expanded that into evaluation, and I'll tell you the names of a couple of new centers that we have that'll give you some sense of where we're expanding. We have a Center for Health Communication Science, and we have a Health Implementation Science Center, and we also have a Social Data Collaboratory. So those are some of the new areas that we're branching into, and to kind of answer your question about evaluation and how to bring together stakeholders. Ironically, I started my career as a case writer at the Harvard Kennedy School of Government, writing about nonprofit organizations and when they merge and acquire and collaboration. So it's been part of my professional journey for a long time, and I think that the principles are pretty evergreen. When we talk about successful evaluation, I think definitely at the outset, really trying to establish a common set of, shared values and shared purpose of what the evaluation is really, really important. And I've certainly learned that even though this is not a highly technical term, but making sure that the organizations that are being evaluated feel like you understand what it is that they're being evaluated on and how that data are going to be used, is really important. Kind of really putting yourself in the shoes of the people being evaluated, if you will, is really important. And the trust building is really it's really hard. I think you really have to work very collaboratively and not see yourself as you are independent, but at the same time, you're working with human beings that are putting their work out there for you. And so being very respectful is a very core part of, I think, being a good evaluator. And, I think especially in the cases where you're working with communities and community organizations, I can't tell you the number of times I have said, if we promised the community that we were going to work with them on this research and bring it back to the community and share, then you have to go back and share. And that is a bright line that you cannot cross. So if you're going to do that, then not only is it your imperative to share back the data, but you have to make sure that it's data that they can use and that's important for them. So we actually spend a lot of time on that part of it, and certainly with our community partners, keeping them engaged through the entire life cycle of research is really, really important.
Thank you. We talked a lot about building infrastructure, it sounds like, for transparency and collaboration that builds the foundation for collecting data, making action. And Roy, when you said the most important thing to do is share, if you say you're going to share, and that tees up perfectly. Heather, I'd love to learn about or hear about the community health needs assessment and what Metopio does is their role in sharing that data, what innovations in data visualization you all look at, and what's most effective to get the data out there for change makers. And then we'll pivot and talk about some of the changes that data has innovated from other folks on the panel.
Sure. Great. So I would say this actually goes very much back to what Dr. Holloway was saying a minute ago about how you agree on a metric, how you work through all of the details of what that tells you, and that you all agree on what it is when you're working with county and you're working with city and you're working with partners. If you just say food insecurity, that could be a lot of things. And in the absence of a single, defined metric that says we know what we're talking about and we know, why it's the important one, to do that work of saying, there are 50 ways we could say this, and we have picked one, and this is why we picked it, and this is how we calculate it, and this is what it's based on, and this is what it includes, and this is where we think it's going to come out. If you make this change, that's where it's going to go. And so some of the innovation is in that really basic work, that really basic, not just the math, but the trust in the math to say, we have really thought this through, and we have agreed that, the pieces that we need are here, and it reflects what you know about your community. We have that local connection to say, I didn't come in and tell you where the food deserts were. You knew where the food deserts were, but I've quantified it for you. And so having all of that together just at the basic level is step one, and that step one is big. So I would say from there, the visualizations and the communication and the storytelling is where you get from, a statistician who really wants your p-values and your r-squareds, and to a community member who does not care. They do not want to learn statistics. They have a job. And so to let them do that job and have a map or a graph. And honestly, some of the best visuals are the simplest. It doesn't take a lot to make it clear, but you have to know that you're making it clear. I love maps. I mean, honestly, my favorite visuals will always be maps. And that's one of the things we do really well. It's maps. But to say, we didn't just tell you it's going to be zip code. Maybe it's zip code. Maybe it's school district. Maybe it's census tract. Maybe it's the area that particular resource serves, that food bank or that, FQH. I'm going to get it wrong, FQHC. and to be able to have that flexibility to say, we're going to make this make sense to your job. And that's where I think that a lot of the benefit can come, is we've got the numbers, we can do the math, but to make it make sense to somebody who does not want to do the math, that's where it's really key.
I haven't heard trust in the math before I wrote that down. And I like that a lot because that gives math a little more human touch, I guess, for someone like me.
It is all human.
And I should have disclosed I'm a Metopio user and have been for 6 years. So I love that tool. So we're able to see the data, use the data. What are some, Shelly, from your perspective, working with FQs? You mentioned COVID. You use that data to inform strategy planning. What are some other examples of when you've taken data and how have you used it for action on the ground?
I mean, at the FQHC level, they're serving the most vulnerable populations. And so having collaboration. So one of the things we've done at Alliance since I joined a little bit over 5 years ago is connect with the state and the city health departments, as well as Cook County, through a project that's funded by CDC. It's called MENS. It's a multi-state electronic health record data surveillance project. But in doing so, we essentially collaborated with the health departments and the FQHCs to create a map, I love maps too, of the hypertension rates across the city area by community area. So we have mapped that data and then worked with with the FQHCs, which we lovingly refer to as community health centers because it's less of a mouthful. But the health centers or the community health centers then are able to do projects. And we've done kind of other things that are funded specifically around hypertension. So I think is one really good example. And there's work that's happening right now across the city around this as well. Things like undiagnosed hypertension. So people are coming in, they're getting tested, they're getting their blood pressure read, and then nothing's happening. And they come back 6 months to a year later, still have high blood pressure. So leveraging the data to more effectively capture those people and get them on medication so that they're actually able to move the needle in the right direction. And looking at the maps to see where are the hot spots, right? We know where things are a problem more so in the city, but sometimes there's things that are surprising. And so using that for the FQHCs to be able to map out what direction they can go in, what kind of resources they might need. Do they need to try self-blood pressure monitoring cuffs? Do they need to send those out to their patients? Looking at those little things to see where are the hot spots and the things that could be done, because the population served by community health centers are the ones that are our frontline workers, are the ones that can't take time off work necessarily and need the resources given to them in a way that they can actually make that change effectively. And also, so then that leads me to the component where things like the community needs assessments are nice because we generally don't have really substantial social determinants of health data. And that kind of data can help really inform what actions are taken at the health center level by the primary care physicians. So one of the things that COVID was an unfortunate positive for was we very much so recognized very quickly, we don't know who's the first responders and who are the first line. We don't know in our data what people's occupations are. And so that was a problem, right? If folks remember when we were doing the vaccine campaigns, you were supposed to vaccinate people that were frontline workers first. Who knows who they are? We don't have that data. So those kinds of things have started changing and shifting in the last couple of years, and there are more resources and things to help kind of create an infrastructure around that and empower the health centers, because a provider probably knows offhand, but it's not in the electronic health record. So on the back end, when we pull data, some things like MENS, which I just mentioned, actually take the data and weight and model it so that we can get a better sense of what's happening in a community and create that dynamic of moving the needle at a health center by giving them information back. Also, returning information is important to the communities and the community health centers because they're the ones that are interacting with these folks on a daily basis. And oftentimes, in the lack of third spaces in some communities, more and more now across the country, those kinds of community health center spaces become a little bit of a third space. And sometimes, like if you look at Erie, they have some school-based health centers. It means they're kind of also a little bit of a third space for young people, a resource for them to come to. In fact, in Chicago, there's a couple locations of health centers that are physically across the street from a school or even connected to a school. So all sorts of opportunities there to kind of bring people in and help change health outcomes for folks using the data that we have and the advancement in the data analysis processes to help kind of shift that needle and allow people to get a better sense of what's happening. And the last thing I'll mention, I'm going to put my Capricorn hat on, is that like the Chicago Department of Public Health has been working with Capricorn now for about a little bit over 3 years, where they're actually trying to take electronic health record data, de-identified, and map it to their own surveillance data that the city gets through the state and other resources to really create a better sense of what's happening in our communities. And they've targeted specific areas that they're interested in. And it's really helping them enhance what they're looking at. Instead of just knowing like a little tiny bit, because that's all they get from what's reported, they're actually able to create a better picture of what's happening in the communities around Chicago. And so there are opportunities to leverage networks like Capricorn to really get huge data sets. So Capricorn has over 12 million covered lives included in their data. And so that gives CDPH now a huge set of data that they can work with to get a much better sense of what's happening, pinpoint certain things, get the kind of data that helps them do a better job with their, not that they're not doing a good job, they've always done a good job, but enhance what they're doing when they're doing their Healthy Chicago planning for the next Healthy Chicago plan, right? We're finishing out Healthy Chicago 2025, so they're working on the next one. Now they're able to inform that decision-making of what the drivers are and what they need to focus in on for the next 5 years with an enhanced set of data at the table.
Thank you for sharing. And 12 million, that is a great data set to have, very impressive and growing. Heather and Shelly, when you were speaking about trusting the data, but also the art and science of it, it reminded me of a story. When I used to do employee benefit consulting, I was looking at a client's data and we were hotspotting, looking at areas where there was increased utilization at EDs. And there was one spot in one state where there was an increase. And so the data is telling us just one thing, and we're trying to dig in as to why there's this increase in emergency department usage just in this one spot. There was a billboard that was put up that had a countdown of how many minutes, RER is open and you can be seen in 5 minutes or you can be seen in 10 minutes. And that billboard was driving the utilization. So just a really interesting example of looking at trusting the data, also seeing what's going on in the environment. So I just thought of that anecdote, and I appreciate the reminder. Dr. Holloway, so based on that anecdote about trusting the data and also seeing what's happening on the ground, I wanted to ask about the county's efforts in opioid surveillance and what data you track and how does that inform some of the opioid interventions, prevention efforts that the county has implemented.
Thanks for the question. For us, we've been working on opioid surveillance for about 10 years now. Since 2015, I got to the health department in 2019. And so there was already an established fatality review committee. We worked with the medical examiner's office, Chicago Department of Public Health, Cook County Health, and their toxicologist there. And so what we do, we use the ME's data. What you guys don't know, a lot of the data on the ME's dashboard is still preliminary. They have a couple months when it becomes finalized, but there are pending cases that we look at and we have to finalize with the medical examiner's office. And so once we do that, we do create a report with Chicago. We call it our joint opioid report. So that's where some of our data comes from. We also use IDPH's death certificate data to validate some of our other data from the ME's office and have final numbers. And those reports take a long time because the data just takes a long time to scrub out. We also have a weekly alert system that is done through some syndromic surveillance. So we use state level data and looking at chief complaints. And so that's just an estimate of what we think is happening. We also work with the Illinois Poison Center. So if there are more than, I believe, 3 cases in one particular area, we then do an investigation. We work with the DEA. We work with IDPH to investigate things like that. So we use all of our resources and come together as a state to support even at the county level with Chicago and things like that. So we do cross alerts and reports. We have sirens and Hans and all of our alerting systems around that. We also look at hospitalization data, both inpatient and outpatient data, and we have all of those things on our atlas. And so we really try to wrap a lot of stuff to understand opioid and to support our population. You know, like many people, it's shifted from prescription drugs to more illicit drugs. And of course, fentanyl is the biggest culprit in deaths. And we've had sometimes like horse tranquilizer causing deaths with opioid. We also are able to look at our call centers, like with 988 and 911. So we do get information kind of a lot of places, but we really work with our community-based organizations to distribute that information to them. They give us information too, and so we can go into our data and see if we see the same things and support them. We have a lot of programming around naloxone training and distribution. So it's a really holistic approach. And a lot of this stuff is done in kind, I must say, like working with the DEA, working with the state. Like we don't have any funding for that. It's just what we need to do. So
thank you. You listed a lot of data sources all coming together for the holistic approach. One data source that Roy mentioned during our prep call that really perked my ears was more non-traditional. Social media sentiment, and I mean, except the millennial in me, and also raising small children about what social media is doing and how we integrate some of those non-traditional data sources into future public health initiatives. Roy, I would love for you to speak to that, what NORC's doing.
Yeah, absolutely. I have some very talented colleagues, including someone called Sherry Emery, who really cut her teeth studying tobacco company marketing toward kids. And she and her team developed kind of algorithms to do so in a rigorous way. So this is not like, typing into Google, like, marketing to kids and then, coming up with, some insights that way. It's a very rigorous methodology that involves, for those of you that want to geek out, like there's sampling, there's inter-rater reliability, there's hand coding, because as it turns out, the social media world is very good at picking up sentiment, but doing a blanket keyword search leaves out a lot of informal terms that we all use that maybe don't correspond to the keywords. And so we have been working at that for quite a long time across a lot of different topics. So not just, corporate marketing to youth, but, one of the neatest examples that I can think of was during the pandemic, there was a mental health campaign that we helped develop. And we use social listening as a way to inform the messaging. So, sometimes you can do surveys and that gives you a cross-sectional look at how a certain group of people are feeling about a particular topic. You can do literature searches, you can do all of that. But we find that the social media analysis gives us some real-time listening capabilities. We only look at public pages, of course, because of ethical considerations. But, we started out looking at YouTube, and now we can scrape, TikTok and Reddit and X and public Facebook and really by different audiences, really try to understand not only what the sentiment is about a particular topic, like opioids. One of the analyses that our team did on opioids, ironically found that most of the messaging was around criminal justice and very little about treatment. So if you kind of know that that's happening out there and you can triangulate the survey data that are out there as well, it's just another tool. But it's one that as more social media platforms emerge, and we know like the age targets and the demographics they're in, we just think it just gives public health a way of understanding what's really happening out there, and maybe also as a way of understanding whether public health campaigns are reaching the audiences that we like to see. Because one of the analyses that we can actually do is we can kind of map the sentiment. So we joke around a little bit like, oh great, looks like we've created our own like echo chamber, like we're talking to our own community but not really reaching out into the communities that we're trying to reach. So that's what we're doing around social media data. And if we have this panel 2 years from now, it'll be a totally different story because it will have evolved.
Yeah, and I'm going to just open up the questions to anyone who wants to answer about evolution and innovations. So what other recent innovations, whether that be in technology or policy, do you think is having the biggest impact today or see a biggest impact 2 years from now from all of your different vantage points? Go ahead.
Don't want to be the one that jumps in, but so there are so many sources of data now, and that is, we talk a lot about what's not there, but there is so much that is there, and not all of it aimed at what we do, but some of it can, very much like social media data, be mined and built into models. Again, not easily, but to really get to that data that we do need. And so when we talk about something, it could be something as relatively straightforward as access to healthcare. We could measure that as, distance to a resource. We could measure that as drive time to a resource or public transport time to a resource and start getting to who really has access. But then we can add in who's not going to go there because they've heard, or because they have been there and had a bad experience, or because, they don't know about it. It's there and they've walked right past it 100 times. And so adding all of those things together in a way that really builds out exactly what we need, even though it was collected for a whole different reason, frequently because of marketing, frequently because of selling, that we could still use that data. It takes a lot more effort, but it has the potential to have that nuance. And I think that nuance can really start to drive action in a way that the more straightforward analysis might not have. So that's what I'm looking forward to.
I think one thing we haven't really talked about is interoperability of data. So I'll wear my AllianceChicago hat to start with, just to be clear. Health centers and actually everybody has to report mandatory reporting to public health jurisdictions, whether that be the state of Illinois, Cook County, or Chicago Department of Public Health, in this state at least, or other county health departments. They always have to report to the state. But right now, health centers and primary care practices don't really get that data back. So one of the directions we're rapidly moving in that I think in the next couple of years we'll see a huge improvement on is being able to have that data come back to health centers or to primary care providers to be more responsive to ongoing situations, right? So for example, I'll use Mpox. There may have been, or let's use measles, actually, that's a more relevant current thing, unfortunately. There might be a measles case spotted in one place. It gets reported to the state. And right now, the state does their best. They'll call up the the clinic, they'll talk to them, they'll do what they can, they'll contact their local public health department, get involved. However, wouldn't it be great, and I think this is where we're going, if the health department could actually send a ping out to all of the providers in that vicinity that if you see someone coming in with these symptoms, it might be measles. You may want to take those measures to protect your staff and other patients in that space, right? So that, I think, is a major thing that we're going to see in the next couple of years that will be a game changer, right? To be able to actually get the data back and help provide the physicians and the healthcare teams with information that could empower them to better serve their patients and protect their populations that are coming in. And the other thing with that is also clinical decision support. So being able to get data back where there's a ping into the electronic health record that the provider knows that, there's a syphilis outbreak happening. You may want to test your patients for this if they're high risk or whatever, right? Having that information come back in a way that's meaningful and empowers the providers to make decisions and help support their patients, not just for outbreaks, but also for hypertension and things like that too, being able to see that data come back from the state and other health departments. So,
Dr. Holloway, any thoughts? Again, the questions on innovation, disruption, what are you excited about?
I think for us, we do rely on a lot of our partnerships to help support innovation in terms of technology. But what we have done recently, we've become an academic health department. And so the data that we have is now able to be downloaded quickly, easily through our collaboration with Metopio. So not only are we able to do correlations, which we can do on Metopio, we can now start with associations to really answer real research questions with the real research partners that can do it. But anyone, right? You can download the data, you can have your proposals and stuff. I think that is very innovative because data used to be like just PDFs, right? Or tables upon tables. And I mean, unless you had somebody who could kind of sit there and remake these tables on their own, like just stuff like that is super innovative. But it's not only at the level of the health department, it's our academic institutions, it's our partnerships, it's our community members. They can do their own analyses, and I think that in a way is innovative. We have a lot of restrictions in the government. We may not know if things could go through. We could have tons of agreements. We could have the money in the bag, and at the end, it could be taken away quite easily. So we're trying to ensure that people have the power, right, to do the work that they want to do. And I think that's innovative. And I know that that's what we're doing at Cook County. We're trying to, we're creating an RFP for electronic health record data. We trying to get that into place. So, those are the source of innovation. It's just like capacity building, but it is, I mean, that in itself is long coming. So that's our innovation, I know, but just the government,
No, not just the government. Appreciating the infrastructure in which all these major decisions are being made and the policy to actually impact day-to-day lives. This wouldn't be an appropriate conversation on innovation and data if I didn't use words like AI or, predictive analytics or things that these folks know way more about than I do. So I want to ask, how do these buzzwords change the way in which you approach health data? Do they not? What excites you or concerns you the most about the influx of AI? Whoever wants to go, but Roy, I'll let you start.
I think if you're a fan of AI, it's a 2-letter word and it's a 4-letter word if you don't, right? And the promise of it, it's enormous when you think about routine data tasks and being able to do things at a speed that humans can't do. I'd like to think of, I have colleagues working on health communication messaging with AI that we're calling AI for good. Essentially, can we, develop some sort of an AI that puts out health messages that are evidence-based and tested, but that's still pretty early in development. And, yeah, I mean, I think we've seen some of the pernicious effects potentially of AI in that space. I think the big challenge is how we're going to harness it as a public health community. And what I mean by that is, those of you that may, have young children, when you tell them they're going to buy ice cream and they're like, great. And then you take them to the grocery store and they're just like looking at like rows and rows of ice cream. And they knew that they wanted the Italian ice, and now all of a sudden they see like 50 different flavors. And so the challenge really is how to take the power of AI and take all this volume of data to create insights. And that translation isn't always going to happen, which is why I kind of firmly believe that my value as a human being is still going to be there at some point, so that someone can make some sense out of all these data. So I think that's, we see the potential in it, but we want to be thoughtful about its potential effects.
I'll pile on to that. Sorry. Yes, my mother would agree with you. She says I mumble. So I would say there is a huge potential for AI. There is a huge benefit there, but it's not magic. You can't just throw, 50 reports in and hope. You have to queue it up, and you have to queue it up in a thoughtful way that gets you to the decision making. And so it's not your new vice president. It's not your new CEO. It's your intern. And you have to say, here are the questions we're answering. Here's the data I want you to look at. Here's how I want you to look at it. Now go do it.
Sure.
And so making sure that you don't put too much on it, because it is confident in its answers. It is convinced it is right. And you're like, wow, that's not what I asked. So yeah, but it can do it.
Yeah.
It's not, I don't know if I'm a fan or not, but it is a good tool. It's there to be used, but it has to be used carefully.
That skeptical piece is very important. I would agree with some of with that you're saying. Shelly, any thoughts?
Everyone's already said what I would have said, but
Double down.
in terms of and the health center side of things, there's definitely a lot of power there. But again, it's about using it carefully, right? And in terms of like on the Capricorn side, there's an opportunity to be able to harness and use large language learning models to do a lot more with the data that comes back from all of the health systems that respond to queries in Capricorn. And by the way, I don't think I mentioned this before, but the point of Capricorn is that anybody can ask a question. Unfortunately, you have to have some funding because the cost of running the queries at each of the health systems, there's a cost there. But the more we get questions from people, the more opportunity there is to leverage AI and large language learning models to take that data and analyze it in a way that might have meaningful outputs. But as Heather said, having to be really mindful about what is the question being asked, how are we asking it, and still having the humans at the table to look at the data and see, is this interpreting it in the way that we told it to interpret it, or is this actually what it is? And that's kind of the big thing, even at the health system level.
I would say that at Cook County, we don't use AI in a way that would analyze data for us at all. We do use it for, say, scripting out things. So if we had something in SAS, we want to put in an R or something like that, we would take the code and change that to support that effort, but we would not have it analyze anything. If you ever use okay, don't tell these to the people in my MBA program, but you'll put data in there, a table, and say, oh, what's the answer? Now, you've written out your own answer, and you see that, say, chat, for example, didn't do it right. They say, are you sure? Oh, you're right. That wasn't right. Like, you're like, wait a minute, so it happens all the time. So that's why I'm glad we're still human. We're valuable. We still mean something, but AI is a long, long way unless you know how to super duper program it. Yeah, I mean, I use it for emails and stuff like that. So because I can't spell or the tense or something like that, but I think we are a long way away. We have to use tons of programming to support AI, but we also need a lot of governance. And so we're not at the level of governance or understanding AI enough, so we just don't use it at the county for any data analysis. We would never use that. But you know, you can make an image, right? Like you create cute images for your presentations and things like that. But yeah, we really don't use AI. And it's not that we don't think it's something that could be viable for us. We just really need governance around it. So we take the approach of caution. Yeah.
I appreciate all those perspectives. Meghan, time check.
Yeah, like 10.
Okay.
You want to do audience or?
Yeah, no, I love to open to the audience if y'all are comfortable with that. I think I saw your hand up first. Sorry, and then we can.
Hi, and this can be for anybody up there. In regards to the ones who are using AI, how are you addressing the governance and stack governance issues in regards to hallucination and bias as it pertains to the data that you're analyzing from the large language models, especially as it pertains to healthcare and government, because you have a great deal of restriction.
Just like I said, we don't use AI for analysis. We use our programmers, our epidemiologists, so they still have a job. That's real nice. And we will use it to convert code. But that's it. We wouldn't put any health-related data into an AI system.
And I will say for health-related data, there are PHI concerns. You can't just feed PHI into a public model. You don't know where it's going. Yeah. Now, if you're talking about something like, here's a bunch of data that we've already aggregated, we've already, decided to use for something, could you write me a caption? We could do that. Now, that's not simple either. You have to be very careful how you wrote it, how you fed it, how you formatted it, and then double check, 50 times that it came out with a fairly simple question, that it came out right. And when you've got it right reliably, you still want it to be checked by a human. It's never the last thing. So, yeah.
Thank you.
Hi. My general question is very basic, but it's like, how tight geographically can you get? And here's my perspective. I work with Westside United, and we look at neighborhoods, and our focus is on life expectancy. And they make sense when we look at demographics, income, except for one neighborhood. And so how tight? It's Walter Burnett's ward. It looks like the rest of the West Side, and then you slip in Fulton Market, and it throws all of our numbers off. But it's been getting better and better and better. I'm just wondering, you guys are cutting edge. Like, how tight are you getting now in terms of our geographic?
So with Westside United, you're with Chicago, right? Mostly. So the health department, I can say this because I work with them a lot in Chicago. When they do life expectancy and life table analyses, they can do it at the census tract. They can do it at zip code level. So they do have that information and data. What does happen is sometimes zip codes cross jurisdictions. So that might be something, but also if you're talking about Fulton Market, where there's an uptick of funding and money and, things like that, I think the census tract is the best level for you to analyze that because there's just a couple blocks. So
I agree. Census tract is the smallest area that I've seen done well. And the convenient thing with the census tract is they're about the same size population-wise. So you're looking at about 4,000 people. When you get smaller than that, it's variable. And when you get bigger than that, you've now combined a lot of groups of people. The way they design census tracts, they try to make them as homogenous as they can. So they're trying not to do two neighborhoods. They're trying to make it one neighborhood. It's not perfect, but it's the best I've seen. Mm-hmm. Oh, yeah. Well, so just a little anecdote. I was looking at ZIP9 data, so the 5+4. And I live in a very densely populated area where my city block has 10 different 9-digit zip codes. And if you look at, it was a consumer behavior metric, and I can tell who's throwing it off. I know these people. And it's weird, it's creepy, but also it's too small. There's too much noise. And the fact that you live next to somebody who has a motorcycle and they spent a lot of money on that motorcycle has thrown off your neighborhood. So yeah, census tract's where I'd go.
So I actually have two questions. So one on following up on the bias. So we do a lot of analysis of the data, and now with certain new policies, people are now going to be coming forwards with their needs, right? And that's just one of the factors. So how do you guys make sure that the data is representative of the actual population that lives there? And then the second question, Roy, I have for you, do you guys see a rise of like fake data, especially on social media, and how do you address that when you do the sentiment analysis?
Do you want to start with the question on making sure there's a generalizable sample, how you ensure that?
I can kind of start to answer that. So one of the key things is there's been work done for quite a while now on weighting and modeling. So leveraging that work that's already been done to just keep doing that, because the reality is we never have everything anyways. And so is it perfect? No. But is it helpful? Yes. It still gives us a pretty good sense of what's happening in a specific region, despite people maybe not coming forward with certain information now.
I was going to say, because I'm not a statistician, I can't speak to the details. I've just been in the room when we've talked about fake data, and does this look, right? There are ways in terms of pattern recognition that statisticians have to identify irregular, data, and we're able to really suss that out. But it's usually with different types of data, it becomes part of a quality control check. So there isn't like one smoking gun. It's just like part of a built-in process to identify irregularities in data and to address them. So I do know I have colleagues that do that kind of work.
All of that. So a lot of what we call data curation is that work. It is the work of making sure that what we have today looks like what we had yesterday, because the things that we measure don't move fast. Poverty lasts forever. Food deserts don't pop up in a day. And so all of that slow movement gives us a check just against history and against, what we would expect to change when something does change. The other part would be these things correlate with each other. And if we had one data point suddenly go off and the other ones didn't, I know which one I have doubts about. But knowing where those correlations have been in the past and knowing that sometimes something does change, sometimes there's a billboard. Yeah. And, that's how interventions work. And if you have an intervention and you see that change, that's the exciting bit. So you don't want to dampen all of that, but really to say, is this believable? Do we have a cause for it? Do we have some mechanism? Or is it just weird? But yeah, there are also little tricks where they always make it wrong. Anytime someone completely fakes data, they're sloppy.
Yeah, I think we have to see fake data on a more systematic level to really suss it out. And I'm having a hard time thinking of any examples of any massive covert operations to mess up public health data on our side of things. You really would have to make a concerted effort to do that approach. We have primary data collection through our Cook County Health Survey. We have our youth risk behavioral survey. It had to be a movement almost to make that something. Yeah, so we haven't seen it as an issue.
You want to ask a final question? Or you, Ashley, if you wanted to wrap something.
Yeah. I think there'll be time, I'm sure our speakers would be happy to answer questions. But I would just like to end on a note. One call to action for the audience to advance public health data. Any takeaways from this conversation? What would you say to the audience just that they can do to advance all these efforts? And Heather, you want to start? You look excited.
And constantly jumping in. I would say just don't underestimate how much work this is. This is not the easy part. And what concerns me about it, and part of the call to action is you already have jobs. You're already epidemiologists or social workers, or you have other things you're doing. Don't make this like what you do on your weekend. It's not a weekend bit. It's something that needs effort and time and funding and work and thought, and that will pay off.
Yeah. Right.
I would say, and this is kind of reflective of some of the work we do in implementation science, which is no matter how much data you have, make sure that you're asking questions about the context. And that's where the human beings come into play, because that's where where the innovations really lead to better interventions, is just know your context, trust your gut, double check your gut.
Allie?
I think really as a reminder to everybody to keep collaborating, because there's so much rich knowledge out there and conversations that can lead to really awesome things coming out of it. So how do we innovate on our own? We don't. It's better to be collaborating. And I think that's one of the things that's been the power of Capricorn and Alliance, that having all these voices come together helps us think about things more creatively and come up with solutions. So innovate, collaborate.
I think reporting back, giving information to the county, saying that we love the health atlas and Alfreda's awesome. No. But yeah, literally just giving feedback and letting people know what's important to us, that we think we should have more funding for data programs. The way data works in public health, we don't really get funding. We get funding through our programs and our initiatives, and that's kind of a hard way of doing things. So we have to kind of piggyback on other programming. But if we say we need funding for data so we can have access to it, that would be very helpful. You can tell Prep Winkle, she's listening. She's listening. But yeah, there really are. That's a real good way to do it. Like, talk to the community, email us, say this, I can send it up. So just really, that's how you can super support us. And Illinois and county has been super responsive, and they want to support people. So
Thank you. I think what I heard after all of this is data is not just sitting in front of a computer typing away as a siloed exercise. It really takes a community, it's collaboration. There is a human element no matter what AI is. There's trust in the math and context that really needs to be considered. And so I just want to thank the 4 panelists up here, not just for your time today, but for all the work that you do. And thank Meghan and HC3 for hosting this event. And I'm going to pass it back to her.
Thank you. We'll give them all around. And we're going to ask you all to move. Thank you. And we're going to transition, and I'll do it while I'm talking, hopefully. So I have the incredible pleasure of welcoming 2 gentlemen that are incredibly thoughtful about data, and I've had the pleasure of being in rooms with them where they geek out. So I am pleasure to introduce Michael Barbouche and David Smith. Michael hails from Madison, Wisconsin. He had to travel the farthest, but he is an incredible thought partner and leader in this space. So he is going to educate us around the clinical data sharing and a lot of the regulatory things happening. And David, my colleague and boss at Third Horizon, is also a thought leader in this space. So David and Michael, I think I transitioned while I was talking and everyone got all of that. So take it away.
Beautiful day in Chicago. Michael, thank you for making the trip down. We kind of inserted this discussion a little last minute. I think about a couple weeks ago, we wanted to hit public health. We're going to talk a little bit about some price transparency data when Michael and I are finished, and thought, oh my God, there's so much happening on the clinical data side, but if you're not following it really closely, it's kind of like a mess. You've got things like Kill the Clipboard and Blue Button and TEFCA and all these things happening, and it kind of feels like nothing's really making it to the patient. So a little bit of history for those that don't follow this. About 21 years ago, President George W. Bush signed an executive order. It was in April of 2004. And it was kind of premised around the notion that, in fact, I think he used this this corollary at the time of signing the executive order. The notion that he had come to believe in is that if a person got in a car accident and there were first responders that came to the scene, there was certain clinical information they might need to know about how to treat that patient. And that clinical information sits somewhere on somebody's server, or back then I don't think we really had clouds in quite the same way. And he said it's kind of just an asinine thing that we don't have a central place where a patient can access their data, and that could be used by a first responder, a specialist, or a primary care doc for the patient. So he signs this executive order, which did a bunch of things, but the primary thing it did was it created an agency in the federal government under HHS called the Office of the National Coordinator. And he appointed a guy by the name of Dr. David Brailer to be its first head. And it was around the idea of how can the federal government begin to create an ecosystem whereby this clinical information comes together in service of the thesis President Bush had. I don't know exactly what the big hallmark achievements of Dr. Brailer were following that. Michael probably does. But fast forward about 5 years later, and you've got something called the HITECH Act that President Obama ushered in. And I think very rightly created about $27 billion in incentives and some mandates under something called meaningful use to induce the adoption of electronic medical records. So now the ability to digitize this information and have it, so you at least had the capacity to put it in a centralized place. Predictably, a lot of money went to a handful of companies that were building these EMR systems, one in particular that's a little bit to the north of us, we'll talk about as we go through this morning. And there was this challenge with information blocking. So fast forward a few more years later, as Obama's exiting, you have the 21st Century Cures Act, which did a whole range of things. One among them was this prohibition on information blocking. It said, hey, we gave you all this money to build these systems. You can't block the data. If a patient wants their data, we need to find ways to make it accessible. And again, kind of nothing really happened. In fact, it's funny. For any of you that know the organization HIMSS, I can't remember what the acronym stands for, but it's kind of the country's marquee IT professional trade association. And President Bush gave a keynote talk there back in 2019, and he's recounting this story in 2004, and he tells the story about the car accident, and he looks at this audience of IT professionals 15 years after he signed this executive order, and he said, how did it do? And the whole room just burst with laughter. Because of the irony of it. Because 15 years ago, we set out to do this, and for some reason, we can't seem to figure it out in American healthcare. So now, several years, almost a decade after 21st Century Cures, we're still trying to figure this out. And a lot of stuff has happened. So what we want to do is kind of take a few minutes to take pause and where are we in that journey? Are we actually going to get to a place where we can figure this out? And what's that going to require? So Michael is my resident expert. He follows this stuff constantly as a company that uses these data to create incredible journey maps for patients and how data flows. Michael, where are we in this journey, and are we making progress? And we'll dip into some of the specific things we've seen out of CMS in the last couple of months.
Well, thanks, everybody. It's great to be here. I have a daughter who's a senior at DePaul, so any chance to come to the city. Dad had to be in town. She was like, do I have to see you? I'm like, yeah, you have to see me. You're like, after class, you have to see me. So,
and I needed a speaker in a pinch, and I knew his daughter was here, so I said, hey, Michael.
So where we are is a whole lot of data is electronified. It's enormously electronified. I have a very good friend who is kind of my age, mid-50s, kind of falling apart. And he's been a hospital CIO his whole career, kind of through the country, different places, so the South, Midwest. And he tells the story of when he got his first, I think he was the, some kind of associate manager in IT or what have you, in 1996. The hospital's IT budget was just under 1% of the total for the hospital. On a good day, we might be at 15% or more today. And our hospitals, I'll speak rather bluntly with you this morning, they're multi-billion-dollar finance corporations now. So if you have 15% of a multi-billion-dollar organization, that's kind of a lot of money. So we spend a lot, but where are we? My perspective is really, I'm married to an internist, and she has looked at my work for the past 30 years and kind of taken a quick glance and said, that would be worthless to me. I could never use that on anything I've ever done, ever. And that's incredibly helpful as a feedback mechanism because, we are all in this to try to figure out how to improve patient care and help the clinicians, but we have to take a step back and think that our well-meaning efforts with the data and the tech are sometimes off the mark. So in the simplest of terms, we're very fortunate to work with systems and hospitals and health plans all over the country. And where we are is all the data is electronified. A lot of data in certain weird parts, like in California, where we do a lot of work, for a whole host of reasons, the majority of the primary care physicians don't want to get on board. They're also not all owned, as we have around here in the Midwest, into large systems. So they just kind of hang out, they're doing their paper thing, and they're just fine. The area that's probably of the greatest interest to me, the great intersection I've had with David going on 15 years, the behavioral health community was largely skipped in that Obama money. They didn't get in on the game. I'll tell a cute story here in a moment about, I've had a weird year. I've been to the White House a couple times, which was definitely not on the plan at the start of the year. And the question was asked within 30 seconds when I got to the White House. Hey, by the way, the behavioral health folks, they didn't get their ARRA. We didn't get our money. Like, what do you got? And the response was swift and immediate, like, well, you're not going to get it. It's never going to happen. And we would never want to waste money on second-tier, low-tier tech like we bought that's left us in this big mess. That was the response. And the direction, which was surprising, was you should leapfrog that. Because what we have today is this mess we're still trying to figure out. It's not helping us. You should leapfrog that and move to modern technologies and modern tools and have that industry, have that group of clinicians help the other side lead the way. So what I would say in kind of thinking through this with David, I want to leave you with a real sense of honest kind of where we're at. But I also want to kind of have everybody think about the way we can all help to make this better. There was a very critical event. It's hard these days to understand what is actually critical with this White House. Not a political statement, there's just a lot that comes out of there. But on July 30th, they had an event and they said, moving to a patient-centric ecosystem. Now, as it turns out, I've been the one using that phrase, patient-centric, quite a bit with the administration. So I'm getting kind of ribbed by some of my friends and colleagues, like they stole my words. I'm like, I'm happy they stole those words if they got them from me. But where we're going, we have these electronic leashes that we carry with us all the time. And there's, in the near term, there's going to be enormous pressure, particularly on the big players like Epic, to make sure all of your data you can have. That's where they're trying to go. There is, without question, an enormous interest for AI and for other things to potentially look at the way that innovation can be unleashed would be through the conduit of us on any app any of us ever download. I agree, I accept, and move on and show me my pretty pictures on my phone screen. And that would be a way that the data would start to flow potentially out into the wild and not to ever know where it went or who had it or what they did with it. So there are enormous financial interests in this country that have done very well and are doing very well financially in monetizing patient data today, but for their benefit. And the group that is most keenly interested in getting on that monetization path often are our delivery systems for revenue diversification. So our delivery organizations, our hospitals and health systems, like, how do we get paid here? So it's a very interesting time with those challenges. There's all sorts of stuff on the acronyms of things which we'll get into, but generally where we are today is, with the exception of a lot of the behavioral health world, a lot of the clinical data is out there moving. And I should say, by the way, before 2004, like, there were companies long, like, when you had to give blood and there was a test tube, they were putting barcodes on that well before 2004, which meant there's a database somewhere, a MISIS or some box that had that and was tracking that. So data is present. More and more of the clinical data is flowing. There's a part we'll get into here next, I think. The only people that really can't see that data would be your clinicians. And that's a big problem that we face today.
Well, and probably a bit by extension, the patients. Now, here's the key. Patients under HIPAA have a right to see these data. They oftentimes don't know how to activate that right. And historically, the way this would work is either there would be an attorney representing a patient in a med mal case, and the patient would give permission to access the clinical data and support of that case, or the patient might just want it because their new specialist or subspecialist wanted it. So they could either reach out to all the different facilities they'd gone to over the course of years, and what those facilities would do is they'd go down to their basement and their walls and walls of Econo-Store boxes, and they'd pull paper files and they'd scan them in and they'd put them on a DVD, and then they'd send a DVD with a giant PDF file to the patient. They had to go get that from all these different places. So talk about cobbling together like a narrative or story, right? That's insane. Or, companies like Ciox would just send reams of paper to the patient. So to Michael's point, it's electronified. And the idea a decade ago was, well, we should be able to let a patient use their directive if they want their doctor to be able to see their clinical record, or they wanted access to their clinical record. They should be able to get an electronic version of all those data. But we didn't have standards through which that could occur. And we had, as Michael said, these fiefdoms, these silos that facilitated information blocking. They wouldn't let the data out. So I guess, Michael, the big question is, on July 30th, Dr. Oz and others announced this Kill the Clipboard initiative, which was bringing together a bunch of health systems, technology companies. Like, what is the big idea? And are you optimistic that we'll actually get to a place where patients can direct that record to a doctor, or they can access it themselves?
Well, I'm curiously optimistic, but not necessarily because of what they announced on July 30th. Let me try to explain that. There are really powerful financial interests in this country, who look at our little part of the economy and go, it's like 25% here, and we don't really have all of our profit coming from here. We need to go. Those folks are very directly responsible for the July 30th announcement. And the July 30th announcement, to be very clear, is essentially, it feels almost, mob-like in that, come on, volunteer, everybody opt in. And they got the biggest of the big vendors there to say, yes, we are part of the solution. We are opting in. In the most cold-blooded, transparent language I can think of, they are saying to all of the large healthcare data stores, you'll become an open data source now. And if we want to connect to it, we will. And that's where this is going. And so it is an attempt to essentially destroy the silos permanently. But the governance, the understanding, the rules of the road, those aren't established. another White House visit, again, never on the radar to be going there, particularly at this time, opening commentary about the potential to use clinical data to drive meaningful improvements in chronic disease. And I was using the example of CKD, chronic kidney disease. Let me pause you right there. We want no more acronyms. I want no more O&C. I want no 5-letter acronyms. I want no 4-letter acronyms, no more standards. We're done with all of that. It's over. And so there's this sense that we will not be seeing the tech industry and the major pillars of that self-create the rules of working well together. Instead, working well together will be determined by likely new entrants who come in and say, I needed to run my AI model. It didn't work. They were blocking me. Go take them out. And that's where the data will move. There was an event yesterday. It was fascinating to me. I live in Madison. There's a small company up there that you probably all know about. And they held their developer day yesterday. I did not attend. I don't attend those things. But like 80 some APIs, everything's free, everything's available, go, go, go. And so I think there's a real sense of going to have to play along for lots of players in order to get the data there. I'll share this though. There is an enormous desire by our government that the stakeholders who need the data the most and need the data the most real time are the clinicians. And, you know, we work kind of like David's group. We work with all sorts of different buckets of data. There's clinical data, the focus of this discussion. We do a lot with claims data. And since there's a lot of money in our space, the claims kind of leave behind this really, although 183 days in the rearview mirror view, they leave behind a breadcrumb trail of all the places that the patients go. And so when you just kind of let the claims, where did they go? A patient would have data in 8 or 12 or 17 different buckets. So you can't really just say, I'm going to build my AI in Epic and we're good to go. I mean, to our prior conversation, there's enormous pieces of data spread about. And if you're only looking at what you can see in this bucket, you'll have a very potentially biased understanding of the total course of care. And so that's where this idea of centralizing it from a patient perspective, I think that's the optimism I have, can come in to say, you know, and when you think about the struggles all of our larger delivery systems are going through today with burnout, with access and other things, when we meet with systems, some of the biggest in the country, in the world, we show them that, like, what do we care about? We care about oncology. We care about cardiology. That's the service line that matters. And then we look at their data and say, you're only keeping 32% of your cardiology service line because they can't get an appointment for 18 weeks. So the family goes elsewhere. So you're not seeing their data because they're not getting that care because they couldn't get in with you, so they left. So you don't have the full view. That's a long-winded answer to your question that where we're headed is more of a market forces solution, not a government acronym or standard solution.
So I agree with that completely. I also subscribe to the point of view that in this particular space, government will need to set the conditions, has been trying to set the conditions. So let me hit on one thing you said. So take Epic, for example. Epic's, the patient data that sits inside Epic systems do not sit in one master cloud with some patient identifier classified by NPI or 10 where the patient goes for care. You've got, if it's UChicago Medicine, it is their instance of Epic. If it's OSF, it is their instance of Epic. So patients could go to all these different places, but those systems are not even interconnected enough. So what you need is this this centralized repository that can pull the data in. And that's this TEFCA, Trusted Exchange Framework. That was kind of the idea behind it. Before market forces can actually take over, you need a mechanism whereby those data can be extracted, it can be indexed, and then it can be accessed by a third party. Why on God's green earth are we not there if we have the regulatory conditions to do it? What is getting in the way? And why do Epic and Judy Faulkner hate America? So you need to edit that out later if that gets posted. We don't do business with Epic, but you never know. They've got a lot of money. I don't know that I'd turn them down.
So,
Just kidding, I would.
so my wife, again, is a clinician. And she's the medical director for patient safety and quality, does all this stuff. She sees patients 4 days a week. She can't go into her record and pull up the list of her patients. She can't go into her record and say, show me the patients I saw on Tuesday. Like it is not established around this type of, in the language for this session, healthcare data is broken because there is no metadata. So in the most blunt of ways I can describe this, and again, we work with systems, very prominent, enormous systems. I won't name them, but no system we have ever worked with at all. And definitely there's no system in this room or represented in this city that would actually be able to tell any of us, well, who are the doctors that work here? They have no idea. If we went and said, hey, pick a system. I'll pick on Rush. I'm not picking on Rush. Hey, Rush, who are the cardiologists? We would go meet with them, and we would meet with the chair first, because that would be the proper thing. And the chair would say, I will speak to my administrator. And then an Excel spreadsheet would come, and it would be this tall. It would take about 2 weeks. And then we would go meet with like the Epic people at Rush, and we would say, hey, by the way, who's in cardiology? Oh yeah, totally got that. It's right here. I have this list. We would then go meet with finance. We'd say, finance, I mean, you guys, like, it's you. What's the list? This is cardiology. So within one entity, within one department, they have no idea who works there. They have then no idea who gets care there. Like, they just know who got care there at some point, but there isn't a memory system that says, so like, who did we see that we haven't seen in 6 weeks that we should have seen? Like, it doesn't know that because it's not capturing the data for any purpose other than rapid reimbursement, rev cycles. And so when I'm approached by all of these wonderful, motivated young people who want to build companies, I'm like, you do you go make that happen, that's great. But like when you figure out how to build your API and you have your Fire-enabled stuff, you're 26 and there's some 27-year-old that's got headphones on and wearing this and saying, so there are 879 different blood pressures here that I can see. I think there's more over there. I'm going to pick this one. And that's what goes in the feed. And so we lack an understanding of who works there, who are our patients, and how do we want to assemble this information before we could even commingle it and share it, right? And you know, we literally, the part that I want to leave this group with today is there's an enormous amount of challenge coming for all of us with the funding cuts to Medicaid. That's really because our big delivery systems aren't necessary. They don't have real shock absorbers to deal with financial change. They can only continue to grow revenue. So this idea that it would not be that is problematic. But the bigger challenge, some work that we do across the country, is the clinicians are all burned out across the board, inpatient, outpatient. And in many ways, so I really love the prior panel. You have to take a step back. We have a form of kind of weird social media-esque debris. We refer to it as the exhaust of the electronic record. So we don't have, like, my wife used to round on her patients that were hospitalized every morning. She was kind of old-fashioned that way. And then once a weekend, or every 6 weekends, she would be on for the group. But that meant she would go to the hospital for her patients who were in the hospital, and then she would talk to renal, and she would talk to different fellows and what have you. That's all gone now. So when my wife is doing a kind of a review, or any kind of quality person's looking at a review, you might have had a patient who was discharged or about to be discharged, and the day prior, there were 39 different people who were messaging about that patient. You don't really have a morning rounds where the attending says, are all 39 of you here? Let's get together. Let's talk about Mrs. Jones. We have just created a Microsoft Outlook circa 1999 ecosystem where we just message. There is, I won't name names, but there is an incredibly prominent health system, just a little bit, not in this state, a couple over. They have a football team that I don't really care about that plays in the horseshoe. I won't name names, but anyway, imagine you're over there in that state. So we do this thing for their leadership. And they said, we want to know who is the biggest senderer of messages each month, right? Who sent the most? And so one month, it was a couple months ago, I'm like probably an incredibly kind young woman, probably 23 or 24, just out of school, works in podiatry. And the podiatrist, what's the podiatrist care about? Podiatrist cares about bunionectomies. But what do? You need those overtaxed primary care physicians to approve the patient for surgery. Gotta go. So this young woman in 1 month at this incredibly prestigious place sent 6,941 messages to the doctors. And, the podiatrist was like, if they don't respond, hit them again. Hit them again. Hit them until they were, and so she's doing what she's supposed to do, which is just, but, this is, what we are seeing is this incredible collapse of patient access through the shrinkage of the clinical FTE. So all the more to this data flowing part, we're going to have fewer and fewer times for people to get in for an appointment, and more people are going to be emailing and calling and what have you, which creates more message debris and adds to the challenge.
Couldn't this be, so I mean, we'll talk about this a little too in the next part of the discussion, but I have a situation right now where I've been saying now for a few weeks that I think we're in the beginning stages of the wheels coming off of the American healthcare system. We've talked about the strain and the like for years, but we've been able to solve that through incremental reforms and additional funding that just keeps the party going and keeps the punch bowl full. And we all kind of pretend like we need to change, but we don't really have to because money's flowing. Now we're restricting funding. We have a workforce challenge. We're going into a year where we are going to see the biggest rate increases across insurance lines that we've seen in 15 or 20 years. It also happens at kind of an opportune moment. We talked a little bit about AI a few minutes ago. The AI's capacity to source through all that exhaust and put together a story and a record for a patient, or to enable data feeds for clinical decision support tools, or to facilitate real-time clinical documentation in the EMR so the physician can actually make eye contact with the patient they're having the encounter with. Like, that capability exists. And yeah, AI hallucinates and it needs guardrails and all the things we've talked about. That's part of our journey. But that pattern recognition, semantic pattern recognition, exists in a way that can be engaging and useful to clinicians and patients. So we have that. We have electronified, to use your words, all this data that sits in these systems, and we've created the regulatory framework through which that can be accessed. Are we going to actually see a world in the next 5 to 10 years? This feels like an economic exigent. Like, this doesn't even feel like a nice to have anymore. We have to do this, and yet I see on July 30th, and I'm being sincere here, Dr. Oz and RFK get up and they talk about kill the clipboard, and I'm like, well, I saw the same goddamn presentation 2 years ago, but nothing's happened.
So I think, like, let's talk about AI for a moment. When I meet these really inspiring young folks who want to build these AI companies, they are all trying to out-doctor the doctor. They are building this clinical brain. And I'm like, so check this out. Like, what if you just did all this low-value transactional crap instead and let them do the doctoring part? Like, you can get to your doctoring nirvana later, but like I'll use my father is an incredibly healthy person, physically, anxiety and some other stuff, particularly post-pandemic, but very, very healthy person. So with our regulatory stuff and some stuff that came through 2 years ago, it's like, oh, no. You have lab results for the patient, get it out. Okay, so my father, again, very healthy, goes and gets some blood drawn, and let's say there are 9 tests. All 9 are gonna come back perfectly normal and just dandy, cholesterol, the whole 9 yards. But the problem is that 2 of the results go out the door to him, and he sees them, and he's like, I'm dying. They are restricting 7 of them. They know I'm dying. They're waiting to tell me. So then he emails them through my chart, like, I'm dying. Tell me why I'm dying.
Give it to me straight, dog.
Right now. So then the 3rd one comes out. There's 6 to go. It's green as well. It's fine. But they haven't responded to my chart. So now it's 6 that are going to kill him. So he calls. And then all 6 of them eventually get there, and they're all green, and he's fine, and he goes about his day. But this has metastasized now into people who don't talk to each other anymore. A medical assistant, a scheduler, a nurse, a doctor, who are all now messaging back and forth about this stupid paranoia. And by the way, like, his results were normal, and before we electronified, somebody like my wife could have never seen those results because they came in, as they still do today at times, on a fax machine, and somebody looked at them and said, there's nothing here. Quickly glanced at a nurse who said, there's nothing here, and they got shoved in the chart and were never looked at. And somebody wrote a letter or something to a person like my father and said, you're fine, see you in 6 months. But now it exacerbates. And so when we see all of this, so what I desire strongly is that we would look at the deployment of AI to deal with so much of the administrative side, because what we've taken away the ability for the clinician to spend time with the patient, because the clinician has to spend time with the electronic thing to maximize the coding. Well, if we could figure out some way to at least get the part about approving the surgery for the bunions to go somewhere else. So this gets into areas around taking low value work away. And what we say to the systems and what we say more to the health plans is, you don't really have time, to your point about being this existential challenge. Like, we just have to make the decision that we're going to take a lot of this junk away. And we can route it places, we can send it places. Some human who wants to work from home in their pajamas and just do a bunch of clicking can become a click machine, but we have to think about routing it away from an ungoverned distribution. In a sense, if I am a newly minted medical assistant and I walk in and I'm excited and I'm eager and I get this question, right? I've been challenging, if you've ever used like Grammarly or any of these things, I'm like, who is sending this message? Like, how long have they worked here? What's their experience? Who are they sending this message about? Have we received 83 messages already about this same person? What are they messaging about? Like, about scheduling? I don't care about scheduling. It's like not anywhere on my radar. Or about labs. Is there a problem with the lab? Okay, and kind of score that message and say, good, love the initiative. We rerouted this to this in basket that anybody can look at and manage, and you'll figure out over time. And maybe think about, if you have a real question, asking your supervisor or somebody, but let's back off on the messaging. One other anecdote on that, on the inpatient side, and this is tragic, like we lead an initiative for the state of Arizona, the whole state, because nobody wants to be a nurse there. And it was weird, it was kind of coming out of the pandemic, and I get this weird call to speak to the governor of Arizona. I'm like, this is a scam, and hey, yeah, so like, the schools and the systems, they all need money for more nurses. Like, and I'm like, yeah, don't give them money. Like, you can give them money, but like, they don't want to work for your systems. That's the problem. So like, you got to figure out how to connect the money to measurement, and you got to figure out how they fix their culture, and they get the money when they fix the culture. So, you know, what's happening in this town and all towns is there are exhausted nurses who really don't go to the bedside anymore. They sit at the nurse's station the entire shift. And you can see this in the exhaust. And they're just banging out as many messages as possible. They're working, but they're not working. There's one nurse on a shift that's going to 87 different rooms and badging in every time. And that poor person, who's the one that's running around, is then met by this avalanche of messages when they get off shift of all of this additional work that's been dumped to them. So this is where the AI and other things come into play to say, basically, we don't know how to run operations at this place. I give the example, it would be the equivalent of running Taco Bell franchises and forgetting to have anybody run the drive-through Tuesdays, Thursdays, and Fridays. That's really where we are.
Yeah. Well, it takes us to the end of the time that we have. On the one hand, I am really optimistic because I believe the policy and regulatory framework exists. I think there is a considerable amount of investment by technology companies and others to figure out how to federate, liberate these pipelines. And I think, to your point, one of the things that's gotten in the way historically is both health systems and EMR companies and the sheer value and their ability to monetize patient data that doesn't really belong to them, but they kind of treat it like it belongs to them. I think that equation is going to start to flip. One, just out of patient advocacy. Two, just out of rote, the evolution of technology. And three, part of where I think the system is going, which is a bit of what I'm going to talk about next, and we'll kind of bring it all together. So, Michael, thank you so much for coming down and taking some time with us this morning.
Thanks, Hula.
Yep. And I'm going to hang up here and talk to you for a few more minutes about one other data element. So this morning, so far, we've talked about the nature of public health data, criticality of that, especially at the moment where we're seeing the erosion of public health norms and institutions really begin to take root. We've talked about clinical data. Now I'm going to talk a bit about pricing data and market pricing data. And then I'm going to kind of try to bring this together into a big, kind of exciting view. Like there's a lot of stuff to feel kind of icky and dour about right now. This is something that gives me some optimism and some hope, to Michael's point, that there might be some forces here that will allow us to solve or address some of these challenges. All right, so I'm going to test it. Funny story, real quick. So 2 days ago, giving a presentation to a big philanthropy group in the same room, had about 40 slides, and I was standing up here and I would click and it wouldn't turn, so I'd have to do this kind of reach thing. And I thought I was clicking it and controlling it, but there was this little delay. Turns out Topher was in the back, and every time he saw me do this, he was advancing the slide. I didn't find out till like yesterday that had happened. So thrilled to know that it works today. So the third rail here. So as you all know, historically, when we've wanted to understand something about the nature of healthcare pricing in the United States, there's kind of a pathway you would take, right? Number one is you might call Milliman or some kind of a firm. They charge you $500,000 to answer 2 or 3 simple questions. They'd have their healthcare researchers get on it. They would use claims data. And claims data would typically be procured from one of 7 different companies that are called claims warehouses. They're intermediaries. They get claims feeds from third-party payers. And different ways of displaying those claims. Of course, you've got to be really, really careful about this to adhere with HIPAA and not let personal health information get out. But you could tell some things about claims. You could create kind of a proxy patient identifier. And to Michael's point earlier, you could see where a patient kind of traveled around. But sometimes you might not have something in that record, or maybe a patient had gotten off of Medicaid and been in commercial, so they'd only been under commercial coverage. So it was kind of an incomplete, you couldn't really get exactly to what was happening in market pricing. You could kind of give it your best guess. So rewind 5 years ago, 6 years ago, first Trump administration. They promulgate a set of rules under something called transparency and coverage. This is out of CMS. They use some existing enabling legislation to do this, so it's not codified by the Congress yet. I'm hoping it will be in the next year or two, but it does tend to have bipartisan support. And the range of different reforms kind of took a bit of a spectrum. So on one end of the spectrum, it was a requirement that hospitals had to post their charge master, or a list of prices for all the services they offer on a website. If you know anything about health, if you've worked in healthcare for like 2 days, you pretty quickly come to find out that the charge master means absolutely nothing to anybody, least of all a patient, right? Because it's not really telling them what they're going to pay or how their services are contracted or a range of things. But on the other end of the spectrum, it required transparency disclosures from 2 different parties. Oh no, Topher. Oh, it worked. Sorry to alarm you. 2 different parties with the third one in tow. So commercial insurance carriers. So let me just break that down for a minute. Commercial carriers like United, Aetna, Cigna, Blue Cross Blue Shield plans, whatever the case may be, that sell fully insured coverage to employers, and plans that self-fund under ERISA, that hire a third-party administrator, a TPA, to manage, adjudicate networks, adjudicate claims, and so on. So for everybody that insured somebody outside of Medicare or Medicaid, they had to post a file every 30 days for that network. And in that file was every single contracted provider, so every tax ID number, every provider ID number, every in-network code that provider was contracted for with a rate. And that got posted in a JSON formatted machine readable file somewhere in the ether, not centralized anywhere. You'd have to go hunt and find it. And that effectuated 3 years ago. So for 3 years, I think 38 months now, payers have been posting these files. Non-compliance in posting these is pretty steep, and I'm gonna probably botch this because I failed to remind myself before getting up here, but the civil monetary penalties for non-compliance are like $80 per member per day. Like, it is a crazy high amount for non-compliance. Predictably, non-compliance, compliance has not been great. Civil monetary penalties haven't been enforced just yet, but we'll get there a little bit later. But these files have been out in the wild for some time. Conversely, hospitals, providers, had to post a similar JSON formatted machine readable file in the other direction. So for every network they contract with, every in-network contracted rate for commercial coverage and Medicare Advantage, they had to post the same thing, but they don't have to do it every 30 days. They just have to do it annually. So these files began being posted 3 years ago. And I'll talk a little bit about the complexity of the files in just a minute. They've been made better over the course of time. And October 1st, next Wednesday, we're expecting to see some new information about where this administration is taking it forward. But the Biden administration effectively implemented these regulations that Trump passed, if you can believe it. And then the Trump administration, through an executive order signed by the president in May, doubled down and went even further. This is a really, really great thing. The other thing we're expecting next Wednesday is the third rail here for drug pricing. So I can actually get great drug information for drugs that go through the medical benefit because I can see that in these contracts under J codes. So there's about 200 drugs of real interest to me that I can see go through the medical benefit. Some of that could still go through the pharmacy benefit, but I can't quite see the pharmacy benefit side of this because PBMs up to this point, pharmacy benefit managers don't have to post those files. We believe and hope that's going to change at the beginning of next year, and we believe and hope that next Wednesday, we're going to see the schema for how that's going to happen. That's been delayed quite a bit, but there's enough anti-PBM fervor out there that we may be getting closer to a place where that happens. So this sounds really great, right? And like the whole idea in the Trump administration was, hey, patients can be able to access this data, so now they'll know exactly what things cost. So, we don't need this charge master thing. Well, the truth is that these files, they suck. They are really, really, if you've tried to access one of these files, this is not a pull it up, export it to CSV, run a pivot table, filter a code in an NPI, and voila, you have your answer. Like the smallest file I think we've seen has 20 billion records in it, 20 billion rows. To make matters worse, as I said earlier, they're federated, they're all over the place. So you kind of have to bring them into an environment. Well, if you bring them into a data environment, our calculation is that the aggregate number of files posted every 30 days exceeds 5 petabytes of data. To put that in perspective, take the Netflix library, all content, all countries, all languages, and a central server. This data is bigger than that. Every 30 days going into the wild. So it's a lot of information. The other challenge with this is that because there's no civil monetary penalties and the initial schema, at least for the payer postings, weren't very great, the data weren't very great. There were a lot of outliers. There's a lot of garbage. You had dentists that would wind up and they'd have contracted rates for vaginal deliveries. Not a thing that I'm aware of. You would have erroneous data. You would have ghost networks. You'd have all kinds of challenges with the data. So one of the things that happened early on was you had companies like Turquoise. If any of you have heard of Turquoise, what they would do is they'd say, hey, we can do the 4 petabytes of data storage. We're going to bring all these files in. We're going to create a flashy front end. And we're going to let people access it. And people would access it and say, I think maybe there's some problems with the data. This doesn't actually match the contract that we have, or this doesn't match our experience. And Turquoise would say, well, call the payer. It's their file. We're Switzerland. So very immediately, the market started to distrust this data. We took a very different approach. I'm going to skip over that because I don't want this to sound like a commercial. But we built out some data processors and systems, which is really what you should do with this, where if you take the payer files and you take the provider files and you take the claims data, which seems just wild that you have to do this, and you reconcile those 3 different elements within a process or an algorithm, you can actually get some powerful information. And it is powerful, but it is hard to get to. So objective hope is that as CMS continues to regulate this, it will become more accessible. The challenge is that today you need people that are a lot smarter than I am to build systems that are sophisticated enough to process the data and reconcile it in a meaningful way. But the data do tell us some interesting things, and it's one more piece of a data puzzle that I get excited about. So I'm just going to show a few things that we've kind of observed from the data in a few different ways. We've looked at it in a few applications for how you can think about these data, and then I'll kind of tie it all back together in the context of the broader system. Some of these slides are probably going to be really difficult to see, so I apologize in advance. I'm not doing an exhaustive study with you guys, and I think Meghan will circulate the slides afterwards, so you'll hopefully be able to get a different feel for them. So question 1 is, what can this transparency data tell us about different healthcare markets? You know, again, if you've been in healthcare for longer than 2 days, you've probably heard the euphemism, if you've seen one healthcare market, you've seen one healthcare market. And there's a very specific reason that we talk in those terms, because every market has 2 competing forces. They should be collaborative forces, but there is a tension between those forces, between who is underwriting the care or reimbursing for the care under a contract, and then who is providing the care. This is the supply and demand side of things in a market. And one of the challenges we have had in American healthcare for 40 years is, where does that market power sit? So we have an incentive problem, right? The incentive structure between payers and providers is not completely aligned, and you've had this information asymmetry over the course of time. And then you have in certain markets this concentration. If you've got competitive markets, and what I mean by competitive is you have a plurality of different health plans that are competing for members or enrollees, or you have a competitive health system in that you have different competing hospitals, that should create some degree of balance. And that's kind of what you see in the middle with this equilibrium. Now, I would make the case that we've never really been at true equilibrium in any market in the United States in the history of American healthcare. Even for markets that are competitive, Equilibrium, market-based equilibrium, requires information symmetry. You got to know what's going on with market pricing elsewhere. We haven't known that really up until the last 3 years, but we do have that information now. So you've got this balance of power challenge that creates these distortions. If on the left, you have 1 to 2 providers that are controlling a majority of that market, they are oftentimes the ones setting the price because they're really the only ones that are supplying the services to the demand side of the equation. So they're the price setters, and that creates a market distortion. In other contexts, you'll have 1 or 2 payers that set those rates. Fun fact, with the elimination of the enhanced premium tax subsidies for next year on the Obamacare, the ACA exchanges, a lot of carriers are leaving the market. Places like Michigan, we've gone from 5 plans that'll be on the exchange now down to 2 plans that'll be on the exchange because nobody knows how to price for it. So that creates a market distortion that puts some power back to the payer in different contexts. But what is so fascinating about this is you think that in an industry like American healthcare, right? There's kind of generally know what it takes to facilitate a knee replacement or childbirth. We know the different tools required, the equipment, the RVUs from the workforce. We can put together what a standard episode would look like and what that should cost. But you see this wild variation from market to market because of these market-based distortions. And when you start to look across different markets, this data can start helping to point out, well, which end of that spectrum are we actually sitting on? And I could spend, you spend hours on a slide like this, really digging into what is this telling us, because it's fascinating. The first thing that my eyes go to is we think of Chicago as one of the most expensive urban climates in the United States. And we kind of instantly assume that, well, our healthcare must be that much more expensive than everyone else. Actually, turns out we're not terrible in Chicago. This isn't an exhaustive view of all MSAs or DRGs. This is DRG 795. So a normal newborn rate ranges anywhere from about $3,500 up to one outlier here in New York that's $17,000. Same base core cost. It's not like it costs that much more money at this facility in New York to have a baby than it does in Phoenix or Phoenix Scottsdale, but you see that kind of range. Look up at New York, and if you're familiar with box and whisker plots, if you're not familiar, just a really quick tutorial on how to read this. What a box and whisker plot does is this bar is the median, this is your 25th percentile, this is your 75th percentile, this is your, these are the bands for your 0 and 100th percentile, and anywhere you see a dot here is just an outlier that we're not calculating in the plot, the box and whisker plot. So in New York, what you can see is a wider variation between that 25th and 75th percentile and an even wider variation for the entire universe of data. So a very wide distribution for New York, really with one outlier. What that kind of indicates is there is quite a bit of provider competition in the market, and the data bears that out. There's, New York's a big market. There's a lot of providers. Nobody's really consolidated everybody in that market heretofore. And this is what's really good when you see the FTC or the DOJ get involved in antitrust efforts. That's kind of the picture we want to try to create. Now, New York is still a high-cost market, so that tells you that there might be some problems on the demand side. Well, that turns out to be the case because payer competitiveness and the ability to set market rates is a bit diffuse. So you have this very just wide set of price variability that takes place in a city like New York. If you look down at Philadelphia or Flint, Michigan is a really good one. There is no variation in Flint, Michigan. So what does that tell you? Well, it tells you somebody's setting the rate in Flint. Somebody has the market power. Well, in Flint, it's the providers. There's a single provider. They own 100% of the market. They set the rate. If you want to be a payer and sell coverage and have a network in Flint, Michigan, or have access points in Flint, Michigan, this is the rate. This is what it costs us to do those things. Thankfully, they must be somewhat egalitarian because they could push that a little bit further to the north. Philadelphia, you actually have a bit of a wider competitive market on the provider side, but a very substantial concentration of commercial payers that narrows down that band. So you these types of visualizations, when you bring all this data by NPI and by payer together, start to present a picture again of how do I start to read where equilibrium is? Because the point is to try to be at the middle so the market can set the rate. We are so far from being in a world where markets set rates in American healthcare. This is a step in that direction, though. And I'm going to talk a little bit more about why here in a minute, because it links back to the other two discussions we've had today. There's a taller version of this. So where Flint is egalitarian, Cape Coral, Bellingham, Washington, Spartanburg, South Carolina, same exact dynamics as Flint, Michigan. One provider, 100% market share. They have the market dominance. They can set the rate. So look at those median rates exceed New York. They exceed Chicago. Cape Coral, Fort Myers, Florida, which is like, it's Florida, so it's nice, but it's not like hitting the lights out in terms of like bougie communities. $8,100 compared to the $3,500 in Chicago. That's a wild price distortion in the market, and yet we've allowed something like that to occur. So the first thing this data can do is it can help us better understand and compare markets, so we can potentially make reforms that might be pro-competition or think about the antitrust types of regulatory structures required to maintain competitiveness in the market, right? As Americans, we kind of determined, like, let's let market forces do their thing and they'll create efficient healthcare. Well, great. Let's actually facilitate the conditions for market forces. This data starts to put us in the right direction for that for the first time in, like I said, 70 years. Then you can drill down a little bit deeper and can say, well, what does it tell us about what's happening in Chicago? And it's funny, Alex, one of my colleagues, and I, who helped put some of this together over the week, we're having a discussion this morning, and you can look at these charts and you can think, like, there's just so many rabbit holes you can go down with every single one you look at. So this is a bit of a choose your own adventure thing. I'm not leading you to one ultimate conclusion. In Chicago, we have a unique dynamic in the commercial market, in that we do have a fairly diverse, we have a fairly competitive provider ecosystem, but it's based in stratas. So in Flint, for example, you don't have a cohort of academic medical centers, for-profit hospitals that are owned by private equity or HCA or CHS, and then a cadre of nonprofit, and then a cadre of safety net. You just have a system. In Chicago, we have all of those different components. And so we have a wider range, even if some of them have started to consolidate within those pockets. And we have two primary carriers that facilitate fully insured coverage for employers, or function as TPAs for self-funded employers. And that's United Healthcare through a POS product that they have, and Blue Cross Blue Shield of Illinois, HCSC, for a PPO product that they have. Remarkably, in this context, the PPO rates, the median rates, are slightly lower than the POS rates. That's novelty number one. You wouldn't expect to see that. POS coverage is typically a little bit lower. So what that might indicate is that there is some market disparity between those two, and there is. Blue Cross Blue Shield has more volumes, and so they have a different strategy in terms of how they negotiate rates. You also look at the variation, and I think the next slide, a slide or two down, shows this in even a better context or detail. But you see this wider band for UHC POS and a tighter band for HCSC, for Blue Cross Blue Shield. What that means is that in a lot of cases, Blue Cross Blue Shield has a standard rates approach that they're taking across these different provider cohorts, and they're not doing a lot of variation with that. Whereas United might be a little bit more tactical with respect to how they're facilitating their contracts. Blue Cross Blue Shield has made some unique exceptions. You see this in the outliers, and you'll see this even more, I think, in just a slide or two. And then you see everybody else kind of in the market trying to figure out where they play. Cigna has tried to come in and underprice the market. They've created static rates, demonstrably through what you see in the data, but they don't seem to be picking up share because of some of the historical stuff in Chicago, and you could look at each of these and tell a little bit of a story about what's happening in our city and how people access these services. There's a different way in which you can look at this and organizing by at least 3 of those 4 cadres I shared earlier. So academic medical centers, nonprofit health systems, and safety net. I'm going to show you a couple wild things on safety net in a second. That's a part of the world you care about. It's really interesting. Top left, I have Aetna. Top right, I have Blue Cross Blue Shield of Illinois. I have Cigna, and I have United Healthcare. And again, I can see some interesting patterns here. I can see for Aetna, Cigna, and United that my medians kind of decline. For my academic medical centers, I'm paying the highest median rate for services. My nonprofits like Advocate Aurora or Endeavor, I'm paying a little bit less. And my safety nets, I'm paying less, but in the case of Aetna, wider variation. So I'm picking winners and losers at Aetna when I'm contracting with safety nets. I might think of Roseland as, I don't think of Roseland as a loser. Hypothetically, Aetna might think of Roseland as a loser and might think of Loretto or St. Bernard as somebody that they really want to pay a better rate to. And that's why you see this wider box. Same thing we showed in the previous slide with Cigna, that tighter band. Cigna doesn't really give a crap. They're just setting the rates for what they want to buy from AMCs, nonprofits, and safety nets. And they kind of run this linearly. You see where they make some exceptions for some of these outliers. United does the same thing. You can see where they've made exclusions or they've tried to kind of deprioritize the participation downstream and keep everything within this 25th to 75th percentile. And then Blue Cross Blue Shield has picked some entities that they want to pay a higher rate to, either because the quality outcomes might be a little bit better, that facility or those facilities might be better at reduced readmissions, or there might be some kind of pay for performance engagement or something of that nature that's allowing for those higher rates. But again, it's fascinating to look at the different strategies here. And on Blue Cross Blue Shield, that they would contract on the safety net side at a higher median rate than they do for the nonprofits. It just begs a lot of really fascinating questions. Well, what does this tell us about provider contracting in Chicago? So facility by facility. And so this is, we're just gonna look at 2, and this is the one that's really hard to read, so I'm sorry, I'm gonna try to translate this for you just a little bit. This is the Blue Cross Blue Shield Illinois PPO, so this is one of those dominant networks that exists in Chicago. And this is the top 20 DRG rates by hospital as a percent of Medicare. So this is like a blended composite of the top 20 DRGs, so a pretty good proxy overall. And down here, anything that's kind of in this green or is in this purple is telling you nonprofit or safety net. So at the bottom, I referenced Roseland a little bit earlier. So for Blue Cross Blue Shield of Illinois PPO, you can see right here that yes, they have included Roseland as part of the PPO network. It is a PPO after all, but they're not paying Roseland. I mean, they're paying them a sub 100% of Medicare rate. That's like literally like a Medicaid rate. You see the same thing with South Shore. You kind of see the same line trend down. The red stuff are your academic medical centers. And then you've got some advocates and other kind of more quote unquote prestigious institutions that sit at the top. But you see where HCSC has kind of made decisions. They tend to live in this area for folks where they want to kind of disincentivize the rate and hence coverage. You'll see them fall closer to this end. And then you'll see for these areas where they might perceive better quality, differentiated services, differentiated contract, value-based care, they might pay a bit of a higher rate. 100%. It could vary. So since this is commercial, you won't see the stars, I think, show up in the data, but I think it's absolutely right Medicare sets so much of the tone for how contracting gets done across the country that, yeah, you look at STARS, you look at HEDIS, you look at other outcomes measures, and you might make the determination that I'm doing a lot of volume with you, you're doing good quality, or the provider may have said, hey, we're a lot better than anybody else, and we're not going to be in your network unless you pay us this rate. But you only ever know that when you look at the data market by market to understand the unique nuances. So that's what starts to make this really fascinating. This is the same view, few more providers, but through that United Healthcare Choice POS plan. And look at like how tiered this is. So this almost looks like they were sitting in a conference room and they made the decision to create these segments, these cohorts and buckets, because you see all the safety net hospitals down here, all south of 100% of Medicare commercial coverage. Then you see the nonprofits kind of cluster up through here. And then you see the academic medical centers kind of trickle up above. And again, shows that how these organizations are choosing to facilitate these contracts. And again, I'm just going to point out that for the nonprofit and the safety net systems, to be at an aggregate on your top 20 DRGs of 100 to 150% of Medicare, that's insane for commercial coverage. You'd expect it for Medicare, you'd expect it for Medicaid. Commercial, if you're not hitting at about 190% of Medicare on a reasonable commercial book of business, you're in trouble. And this shows that market dominance, that power truly is being set by these two. So where you might have in Illinois all this competition with all these different networks, for whatever reason, there are two networks doing about 75% of the enrollees, the claims adjudications, the network facilitation, and hence you've got this kind of pricing distortion that occurs in Chicago. So moral of the story for a place like Chicago you'd want to think through is lower healthcare prices. We need to find a way to be more competitive on the insurance side and create more variability, optionality, which will then in turn be good for providers and create some sustainability downstream. Or you could ask one of like a million other questions and dig into the data, and it's going to start to tell you a story. We've never had data like this before. And this is what I get so excited about because there's all kinds of applications you can use with these data. I'm gonna skip that for this morning. We've been working with this data now for about 3 years. And we've helped clients facilitate negotiations. So we have one example of a client mental health clinic that said, hey, we're pretty sure we're not getting paid at parity with these guys down the street with Aetna. We looked up, sure enough, they were off 10%. They get on the phone with Aetna and they say, hey, we think these guys up the street are getting 10% more than us. And Aetna says, nah, we promise you they're not. And they said, well, actually, your data says that they are. And Aetna said, well, let us call you back. And they call them back 2 weeks later and they said, you know what, you're right. Our error was a data problem, like some intern. We're gonna gross you guys up. And they got a better rate. Like we've seen that happen over and over. So cool when you see that happen, by the way, for safety nets and mental health. Case rates. We used to have to set case rates or bundles or capitated rates on the basis of what we saw in claims. You can actually now use pricing data. I can benchmark with a good grouper rates from other networks, claims data, and core RVU data, and I can give you an incredible estimation for which providers might be hosing a payer or which payers might be hosing a provider. Network navigation, we have data flowing into a tool right now where patients select a provider based on the cross-section of the cost and the quality. So that payer has said, hey, if we show you, patient, looking for care, where the best quality place is, if you pick one of those places, we're gonna give you a discount or a rebate. That is working. We can actually do stuff like that now. Network modeling, we have brokers actually out working with employers and saying, you're doing all your business at Duke. If you moved it over to UNC, you would save this amount of money based on the claims volume you're running and what we see in the pricing data. Real time happening right now. If I want to expand markets and understand the market dynamics of a different place to do M&A or to expand my services, I can do the same. And again, regulation or antitrust, seminal, a really incredible tool for government to use if government could put together the right systems to use these data and analyze them in the right way. The thing we've put together is something called StarSet Analytics. I never do infomercials in any talk I ever give, but I will say we have a platform that maps this data out. So if anybody's interested in that at all, let Meghan or somebody know at the tail end. I'm going to bring this together and turn it back to Meghan. I think the thing I'd like to leave you all with this morning is that this is a super complicated moment. And as I said a few minutes ago, I think we are, for the first time, we are seeing the wheels start to come off of the system. It's going to start at the safety net, but starting next year, there is no more employer commercial cross-subsidization, bail everybody else out game. We have fixed government rates. We're in a soft labor market. Commercial carriers are going to think and engage differently. The size of the $5 trillion annual pie, it's not going to continue to increase. My point of view is that that is going to make everybody fight more fiercely for the dollars that are in the system. And fighting for those dollars in the system will require an alignment of financial interests. An alignment of financial interests is code speak for value-based care. And the things that will enable, supercharge, make possible value-based care is the ability to set the right price, conjoin it with the right quality, and then have the right access to the right clinical data to support the responsibilities that you have to deliver those outcomes for that patient. So on the one hand, I'm actually excited that the healthcare system is under a lot of pressure because to Michael's point earlier, that might be the catalytic thing we need to get off our asses in this country and do what we do know how to do. We know how to build value-based models. We haven't had the data that's allowed us to do that on the pricing side and to support management of patients. And I think because of the existentiality we're walking into, that will be a path for the market. It's either do that or wait for government to step in and fix it. And we probably have a few more years until we're stable enough as a nation in the political process to see government play a meaningful role. We're going to have to lead in the private sector. We're getting the tools, but there's a lot more work to do. So I apologize. That was a lot to jam into an hour, and I didn't leave any time for Q&A, but you can grab my colleagues after, or you can reach out to me when the meeting's done. And Meghan, I will pass it back to you.
Thank you, David. Let's give him a round for doing a double dip. And thank you, as always, for distilling pretty complex stuff into, I hope, palatable and digestible information to take away in this ever-changing climate. I'm also now pleasure to turn us over to our Bright Ideas portion. So I know there's a lot of doom and gloom throughout, and then there was also hope, and there's a lot of confusion. But I am constantly energized by the opportunity to hear from entrepreneurs and folks that are thinking differently of like, what is the problem and how do I solve it? So I'm going to turn it over to our friends and partners at Matter to kick us off in our Bright Ideas segment.
Thanks, Meghan. Yeah, that was very depressing. And, you know, one of the things, we spend a lot of time digging into different aspects of healthcare, and healthcare data, like basically every other piece of healthcare that we dig into, is a mess. We do lots of roundtables and insights and really trying to understand what's going on. And it's frankly all a mess. The thing that gives me hope is the thing that actually David concluded with, and the fact that I don't remember who it was, Michael or David or somebody earlier was talking about how the healthcare's data used to be locked in file folders, and not really that long ago. And it is incredibly complicated data. And as it gets digitized and as we go through this process, we're sort of moving from the early stages of the availability of data to more sophisticated analyses. And what David just showed and said, we've never had the data like this. And just the ability to do things like those analyses gives me optimism every day. We work with hundreds of entrepreneurs. We run an incubator for healthcare startups. We've incubated about 1,000 companies since we opened 10 years ago. Most of them, especially these days, are ingesting data in different ways. They're figuring out how to collect data in different ways. We have a lot focused on the kinds of problems that Michael was talking about, the sort of back end, less sexy administrative stuff that just gums up the healthcare system and eats up costs. We have a lot that are focused on patient facing, on clinician facing, and they're all, working to ingest data and in different ways to improve various parts of the system. The thing I'll just come back to you to before I turn over to the entrepreneurs, one of the companies that has stuck with me since for years was a company that was started by a gastroenterologist, and he was frustrated that he didn't have visibility longitudinally or over on a more continuous basis to his patients with inflammatory bowel disease. And so what would happen is he would see them in his office, and then he would get a call a few months later from the hospital saying, hey, your patient is here, you should come see your patient because they probably need surgery, they're really not doing well. And he just kept thinking, if I had information about them, if I had data about them, if I had any way of getting visibility to them along the way, I could have adjusted their medications. We could have talked about stress levels. We could have talked about nutrition. We could have designed interventions to keep them out of the hospital. And so he built that. He built a system, very sophisticated analytics on the back end from a patient experience, very easy to use. He had like 85, 90% of his patients would use it every single time. Ran a study, several hundred patients, a pretty rigorous study, found that hospitalization rates on patients who were using this versus not dropped 50%. The overall cost of care dropped more than 25%. And then you couldn't sell it to anybody because we don't have a value-based care system. And the thing that David was talking about with this alignment of the economics of payers and providers and patients and suppliers and all the rest of it, it didn't fit. So he would go to, I remember I mentioned to one of my friends who works at a health system, which I'm not going to name, and he's a terrific guy. But when I described it to him, the first thing that he thought to think about was, well, why would we want to do that? And, he's just thinking, he works in analytics and he was thinking about costs. And he's like, okay, well, all those surgeries, those are very lucrative. And so we can't justify paying for something that then costs us money. And the insurance companies that he went to, it just, everything is so complicated. It's such a challenge to implement that this wasn't high enough on most of their priority lists in order to reach a level where they were really excited to do it. And we've seen that's sort of the most dramatic example that I can think of. But we've seen a lot of these kinds of companies that struggle to harness data and then develop an effective and functional business model in the kind of healthcare system that we have. That said, the farther we move towards value-based care, the more we're able to harness data like this, the more data that's available for people like David building these things to analyze, the closer we're going to get. And I am similarly optimistic over the next few years that we're going to keep moving in that direction, and that we'll have, I think it's sort of slowed in the last several years, but I think we might see some step changes in that direction that will enable a lot of data-driven solutions to improve health and improve healthcare and improve the efficiency and the outcomes. So all that said, we incubate lots of startups here. We run startup accelerators. We partner with big healthcare systems and insurance companies and life sciences companies and foundations and universities to help advance solutions to accelerate the pace of change of healthcare, which is what our mission is. You're going to hear from 4 companies today. 3 of them are part of Matter. They're all innovating in different ways. They're all using data in different ways. The backgrounds of the people who started them are all different. They come from healthcare. They come from technology. And they're the kinds of people that give me hope every day. I get to come to this place and work with people like this who are incredibly passionate about innovating and improving healthcare in different ways, and they are succeeding at chipping away piece by piece at a lot of these challenges and a lot of these problems. So the first one is Christian Stoll. So he is the CEO and founder of a company called Joystik Life. He spent 10 or 15 years at Advocate Aurora Health, and applying his expertise on this premise that technology, if harnessed correctly, really should enable people to live with less stress and ultimately live healthier, happier lives. So with that, I will turn it over to Christian.
Hello, everyone. Christian Stoll, CEO, co-founder of Joystik Life. Pretty much we are a digital health application solutions focused squarely on stress, as was mentioned. My background is with Advocate Health for 13 years. Before that, I had personal experience with stress. I was a student athlete, which led to chronic stress, which led to anxiety, which led to addiction. So that started my story. That's a different meeting. That takes more than 4 minutes. So things got better. And we really wanted to realize that my problem is a lot bigger. Right now, Gen Z is the largest generation that's out there. They also have the most stress per any generation. They're having around 60% overwhelming daily stress. 90% of student athletes in that population, as well, have overwhelming daily stress. This is impacting mental health, physical health, burnout, retention problem at universities. Typically, you think of meditation when you think of more upfront solutions, mindfulness. A lot more focus has been on sick care, telehealth, especially once COVID hit. So we really wanted to make a difference. Something more approachable, something more engaging, something more data-driven. So we created Joystik. At the foundation of it, it's pretty much an app, but it's based on autogenics, which is a more Western scientific approach in this space. It's a true mind-body medicine technique. The cool thing about it, it's very easy. Suffering, trying to get into meditation for years, got into this very quickly. It's evidence-based, and there's also an athletic spin to it, which I thought was interesting. So we kind of started building, enhancing it, personalizing it. You can now get it on Apple, Android. We provide conditioning as well, like Pavlov and the salivating dog, to provide an on-demand benefit to the folks that really need it quickly, right? So engagement, retention, and we provided data for now with our solution using perceived stress scale. So on the app, that's kind of our base. We've also partnered with Ultrahuman, which is a global wearable company. They make smart rings, smart home devices. We are partnering now with Cleveland Clinic and Kent State University on some really cool studies that are about to kick off. Again, focusing on more sport to make it more engaging. So we're looking at injury recovery, not just performance, and then mental health as well. So that's kicking off. We partnered with Concordia University this past year, hit it out of the park with that study with their student athletes, turned them into an investor and our first customer, I would say, in the university space. Now we're in talks with University of Louisville, Cal State Bakersfield, and a few more, University of Maryland. We're about to kick something off with 2 of their teams. We're also about to partner with professional teams, and this is beyond US. We're in conversations with Sevilla FC, which is a Spanish football club. So we really are, as you can tell, trying to really dive in and make this engaging and have an omni-channel kind of distribution and strategy. So we'll partner with Cleveland Clinic and other health systems. We can bring in something more consumer-driven, more engaging, and really for the population that needs it the most. So I think the call to action here is really, I think we're I would say out of the box a little bit with some of our strategy, but we're starting to make chips and dents into the healthcare system as well. I'm from Advocate. We've chatted with their digital health committee. Things might be spinning up with them. And if there's any interest to chat on a pilot or just conversations, or if you know anyone, would love to chat more. Thank you.
I'll invite Vanessa from CareVitality up.
Well, my name is Vanessa. I'm with CareVitality. I've been in healthcare almost over 25 years. I actually have a clinical background. Was supposed to go to medical school at a gap year and pilot a health tech MBA for Loyola University, Chicago, when I was 22. What ended up happening is David was talking about the whole transition, getting everyone computerized. I was involved in that whole transition. I had a national consultancy with people all over the country, even all scripts here, licensed my team. So I've seen all systems all across the country, all the electronic health records, which is actually while I was doing my consultancy, I started my second master's in AI at University of Chicago back in 2014 because I was interested in data, which helped me actually also involved with building CareVitality platform along with seeing every electronic health record in the country, revenue cycle system, and I also got certified to build them from the ground up when I worked at the vendors. So I used to work at Nexion and my Stoll scripts, but I've consulted on everything. So when I was at University of Chicago, we took a database class, which also helped me understand how to develop a platform along with my other background. And I am proud to say it's been 9 years. And I built something that a lot of the investors didn't believe I could do. A lot of them told me I should only do one or two things. And I'm just proud to say, oh, wow, I've built a platform as one of the most comprehensive enterprise platforms in the country to do virtual care management. Not only does it do chronic care management, it also does principal care management, which is specialty care management for specialists. It does behavioral health case management. It does remote patient monitoring. It does transitional care. And the latest thing that came out with Medicare, which is going to be further involved with, as we're seeing move forward with AI and machine learning, predictive analytics, is the advanced primary care management model, which is a combination of chronic care management and specialty care management, which they call principal care management. And what this does is this now does not tie revenue to time for a clinic. So this is where we're adding more of, and it has to do with, risk stratifying the population, also doing the care management like we usually do, but this is where we're initially introducing more of the AI aspects. So we already use AI today with all the other things that we do to build patient-centric care plans. And some of the care team uses that to further because there's, thousands of chronic conditions, but the platform has thousands of chronic conditions already built in with ideas of what you can use, but we use AI to further define. And then we're also, from what Michael was bringing up earlier today too, we're going to use, we use AI to help with, as we're moving forward with the training, but now it's good because he brought up a topic of, all the questions that come in as you're rolling out a clinic. So what I thought was good too is eventually we'll probably use AI to help with that into not only doing it to rolling out and utilizing the platform, but for each specific organization to have their own types of questions because they keep coming back at us at times. But then you have like one area that when it's this clinic you're working on, how they want this handled in policies and procedures, because there's always some types of outliers. So that builds the knowledge base so it doesn't drag down the team. But there's other aspects now that AI is going to be using the platform to help create the notes and things like that. So, AI and things like that, we already have some pieces of it already in, but we have a whole roadmap for this year of how we're integrating it. And it's what's nice with this is that it helps people become more efficient. And I think further along the line, the advanced primary care management model, once things get fixed out a little bit further with CMS, will be more of a model. Because it's similar to the other things that we do, but now it's allowing for efficiencies with AI. So I'm very proud to say we've got where we were. I bootstrapped the whole thing. I have two other companies, a cyber company, CareVitality, for 17 years, and my national consultancy. So I got all this in defiance of what some of the investors said. They thought I could only do one piece of the platform. They said, just try that. They didn't believe I could do it.
I did it, and I did it all with my own money. So proud.
Thanks, Vanessa. And it's hard work. And so it's really inspiring to see the entrepreneurs that are making it happen. So I'm going to invite Tomás from Ion Stewards Energy.
Couple pounds of hair ago, back from 2020. Tomás de Medici, very appreciative of the opportunity to share a few minutes with you all. 20 years in sustainability, impact, and storytelling. And I started a company last July 2024, because I saw that the regulations and how we tell the truth and how we measure things, such as where we walk, what we breathe, and what's powering those lights, was going to change. And there were going to be a lot of gaps resultant. Where we really focus is how that intersects with the healthcare ecosystem, and particularly the insurance ecosystem for risk management and due diligence. So those are the type of partnerships we're looking for. I'm going to speak very briefly about a few of the things we're working on, because I heard the recurring theme of how do we tell the truth and how are we measuring the truth. We're not trying to tell the whole truth. We're talking about a few things: where we walk, what we breathe, and what we use to power those lights. So in one instance, we're measuring the deregulation and changes in development, and what is being measured at the municipal level and development process level, what is being promised, what is being implied, what risk is being created, and then where are all these gaps, and turning that into actionable strategies, because these are going to be compounding issues for our healthcare systems, our due diligence systems, and our insurance providers, particularly within the capital stack. Another example of work we're doing is working with a survivor-led nonprofit focused on a particular type of cancer. We identified 13 geographies within Chicagoland where there were high rates. We identified one of those over 1 year, incorporating qualitative, quantitative, and community-led feedback and direction. And now in our second year since me being involved, we're focusing on the environmental pollution and how that translates. And then finally, we are working with community partners who need help thinking about how they tell these stories in these periods of change, particularly if you are a safety net hospital and you're thinking about, well, what comes next? If we're thinking 90 or 2 years down the line, and we may or may not be here, who do we need to engage with? How do we price that out? And what does the air, the land, and the lights mean for all of that? So very appreciative of the chance to have a few minutes. Would love to chat with folks, particularly on the ecosystem side, hospital systems, safety nets, and insurance for how we can be an asset. Thank you.
Thank you. And last but not least is Margot from Mind Metrics.
Well, before this, I was a little bit worried we were going to have to compete with the EHRs, but it sounds like we're set. So imagine you are going to your primary care doctor with excessive thirst. You tell your doctor you're thirsty, you've been thirsty for a while. They look at you, they ask some questions, and without doing any blood work at all, they diagnose you with diabetes and put you on insulin. Now, had they done blood work, they would have seen that you had anemia and, in fact, really needed some supplements, some iron supplements. Now, insulin versus iron supplements. This is actually the standard of care today in psychiatry. So with psychiatric conditions, diagnosis is usually made with a conversation, possibly a rating scale, asking a few questions, and that's it. And that causes years of suffering for folks who, have been misdiagnosed and have gone on without the support and without the medications that they need. My co-founder, Dr. Joel Young, runs a large outpatient clinic. He's a psychiatrist and had been really fed up with this and had seen his patients for years struggling before coming to his clinic and finally getting a more precise approach to diagnostics. So there are pharmacogenetic testing companies. There are companies out there who are kind of aggregating genetic data to help you understand which medication might work best if you have depression, let's say. But there's nobody out there trying to help figure out if it's actually depression that you've got to begin with. And so depression, ADHD, maybe depression and ADHD. And so that's where we got together and started Mind Metrics with the mission to change that. Our goal was to make assessment of mental health conditions as precise and actionable as physical health. So Mind Metrics is a comprehensive digital assessment tool that patients can take at home or in a clinic, and they share the results. The results are shared with their provider, and it helps providers make a much more informed decision because it screens for 60 DSM-5 like psychiatric conditions spanning from mood conditions to anxiety to substance use to eating disorders, suicidality. It helps providers base their care on actual data as opposed to going forward with trial and error treatment, which is the norm in the space. The assessment we're finding is making for much faster time to feeling better for patients, a much better decision-making experience for providers, an easier decision-making experience for providers, and then on top of that, much less cost, obviously, for the system, being that folks are getting the care they need much sooner. In fact, we did a recent outcome study where we were able to find that patients who received Mind Metrics at the start of their care got feeling better essentially about twice as fast as folks who did not. And so I want to share that we're growing. We're in clinics today across the country. We're trying to share awareness of what we've built. We think it's a way, on top of that, we do have a data set that is growing. So not only is care improving for patients who use Mind Metrics, but it's also feeding a data set that we think could be very valuable for future decision making. And so we really think that this is the end of trial and error care and invite folks who are working on solving behavioral health problems to chat, and very thankful for Matter for inviting me to speak up here today.
That is the end of the long journey this morning. So let's give a round for everyone that contributed today. I just want to give a shout out to Ashley, Roy, Heather, Alfreda, Shelly, Michael, David, Stephen, Christian, Vanessa, Tomás, Margot. Those are just a few of the names in this room, but all of you showed up today. And so I hope that your contributions in learning and being part of this discussion are felt. And we actually are a little ahead of schedule, so you could actually get a little chat in with each other. So thank you very much. I just also want to point out this will be recorded and shared on the HC3 podcast, and that's available wherever you listen to podcasts, as well as our YouTube. And also a recap will be shared on our website with some of those slides from David's presentation, as well as links to several of the startups. So all of those resources, as long as you're registered, will be shared with you to recap and also to share with your network. We really couldn't do all the work that we do in creating this platform and community without you showing up. So I appreciate you showing up here on a Friday. And with that, I will let you get to it to say hello to each other, meet one new person, and get your weekend started. Thank you.